Vanilla, maybe you can make a quick call to Shiv and then start.
Yeah.
Preeti, looks like Priyanka hasn't yet joined. A quick call to her.
Yeah, she just emailed me her this, her slides, and I think she's joining. She's joining in.
I hope she realized she has to use the new link.
I'll just send it across to her.
I think we've lost Shiv. I'm not able to reach him. Should we?
Actually, Shiv just muted me now, so I'm assuming he's there.
Can you see me?
Yes.
Can we start, Shiv?
Yeah, we can. And can somebody check again that we are actually live on this symposium, because I have.
It does say live on the top left-hand corner.
Yeah, it is. It is live. Okay, there are actually people watching it as well. I will actually, I think, so what we have is, so I'll start again. We asked.
I think, sir, the YouTube link has to be resent again, because the old link still
No, YouTube is working. People are logged in. Yeah.
Okay, fine.
Okay, all right. Good morning, everyone. We're going to start again. So this is first in the series of the Obstetric Symposium. Today we have a few lectures and some interesting cases. We'll start off with trauma in pregnancy by Uma, followed by impact of increasing age and assisted reproduction in pregnancy by Vidya, which will be followed by some interesting cases. And then at the end, we will actually have some Q&A. So the lead for this is Dr. Vanilla, and she's consultant in anesthesia and HDU at Apollo Women's Hospital in Chennai, and has special interest in difficult airway, obstetric anesthesia, safety and quality in operation theaters and laparoscopic surgeries. And then we also have Dr. Vidya. Many of you know her. She's consultant anesthetist and head of department at Malar Hospital in Chennai. She too also has interest in obstetrics, pediatrics, nerve blocks, low flow anesthesia and quality and patient safety. And then we have got Preeti, who is consultant in private practice. She's attached to Curran Hospital in Mumbai. She also has special interest in regional anesthesia, on-arrival blocks, trauma, obstetrics, and difficult airway. Uma Hariharan, again, a lot of you already know it. She is a associate professor working RML Hospital in Delhi. And she's trained in the Armed Forces Medical Colleges, and she's done her MD from Sir Gangaram Hospital. She's also got a diploma in European Society of Anesthesiology, that is EDEC. She's a member of National Academy of Medical Sciences. Yeah, I mean, she's got lots of degrees attached to her. She has special interest in biomedical research, onco-anesthesia, palliative care, ultrasound guided regional anesthesia, and then the adult advanced trauma life support. And last of the speakers is Dr. Priyanka Anand, who is attending consultant studies at Akash Super Specialty Hospital in Dwarka, Delhi. And she has special interest in regional anesthesia, ultrasound regional anesthesia, pediatric anesthesia, and obstetric anesthesia. I think with this, I'm going to stop sharing my screen and we'll hand over to Vanilla. And she will take us over to, through the whole day. Over to you, Vanilla.
Thank you, Shiv. Thank you very much for giving us this platform. So it's been a while since we had an obstetric session. I think it's been a year, and then we had one in Take On. So our first speaker, as you know, Dr. Uma Hariharan is very interested in trauma. She's also an ATLS instructor, and she's quite widely interested in this. So she'll be the right person to give us a talk the next 15 minutes on trauma and pregnancy. Over to you, Dr. Uma Hariharan.
Thank you so much, ma'am, for your kind words. I'll just start sharing my screen. Just a minute. Is my screen visible, ma'am?
Yes, you are.
Okay. So without wasting much time, I'll just go on to a brief description about trauma in pregnancy. Because of paucity of time, all aspects of this wide topic cannot be covered. But yes, one must remember that here we are dealing with a very different and a difficult scenario where we have two patients, the mother and the fetus. So all kinds of trauma which are there in any normal population are also found in a pregnant woman, most commonly the motor vehicle crashes or accidents, but also they are subjected to a different kind of trauma, that is the domestic violence, intimate partner violence, which I'll be coming towards the end of my lecture. So the main goal of resuscitation in such patients is maternal stabilization, because the chances of fetal survival and stabilization depends upon the survival of the mother. So hence, we have to depend upon what are known as advanced trauma life support principles or ATLS principles for trauma patients, which are same for both pregnant and non-pregnant population. And that is A, B, C, D, and E. So we have to remember this mnemonic of A, B, C, D, E for every trauma victim, be it pregnant or non-pregnant. A stands for airway maintenance with restriction of cervical spine motion. This is important because in any kind of trauma, the airway kills earlier than any other. The problem with airway or airway obstruction or any kind of airway problem is a life-threatening thing, and it has to be combined with stabilization of the cervical spine till any fracture or any injury to the spine is ruled out, because during airway manipulation, you are likely or liable to manipulate the cervical spine, and that can aggravate the injury further without even your knowledge. Second comes B for breathing and ventilation. One needs to assess the breathing pattern and the breathing difficulties and the various problems which can arise in the B part, like tension pneumothorax, simple pneumothorax, hemothorax, and various aspects of injury to the chest, and deal with them then and there before proceeding further, because they can be immediately life-threatening. For example, if a patient is diagnosed to have a tension pneumothorax, please do not wait for a diagnosis with an X-ray or a CT scan. Put in a chest drain and immediately relieve the tension. Then comes C, and that is circulation with hemorrhage control. This is again very important because you need to identify the site of bleeding and control the hemorrhage with all possible means, because that can lead to various problems. But in a pregnant woman, please remember that the signs of shock are late to develop because of the physiological changes which every pregnant woman has. Then comes to D or disability, that is the neurological assessment and maintenance of the cerebral perfusion and circulation. And E is last but not the least, exposure with environmental control, in the sense that you need to expose the patient with, of course, screens all around, and with taking care of the temperature of the emergency area so that the patient does not become hypothermic. So that is very important. Now, this approach is known as the initial assessment approach, the initial assessment of the woman who is pregnant and injured and brought or being brought to the hospital, either by the pre-hospital trauma team. And we need to prepare the emergency area, and so that we can triage the patient as per the injury patterns and as per the urgency of treatment. So the primary survey and the secondary survey are there in this assessment approach. But remember that there is one more life which we need to look into, and that is the life of the fetus that needs to be stabilized after the primary survey, which involves immediate resuscitation of life-threatening injuries. Adjuncts to the primary survey and resuscitation, like you can insert the orogastric tube and a Foley's catheter, and consideration of the need for transfer of the patient to a center which has obstetrics facility, because this is very important, especially in a periphery where we do not have neonatologist or fetal medicine or obstetrician facility which requires in that particular patient. Then we need to consider transfer. But remember that transfer can only occur after primary resuscitation and stabilization of the injured mother. Now, after this, once the mother is stabilized, look for the fetal heart rate, the continuous fetal heart rate monitoring and stabilization of the fetus. And then come on to the secondary survey, which is again a detailed head-to-toe evaluation of the patient along with history taking, and then continued post-resuscitation monitoring and re-evaluation so that you can identify any signs of deterioration in the patient, and then consider for definitive transfer. Now, this is a mnemonic very commonly used in any trauma victim, and that is known as MIST. M-I-S-T. M stands for mechanism and time of injury. You need to understand that what exactly is the mechanism of injury. For example, is it a blunt trauma or a penetrating injury? And the time of injury. For example, the patient has been injured several hours back, and the patient has been brought to your institution or hospital after a time gap of, let us say, 24 hours or 12 hours. Then you need to know that what are the problems which would have occurred in the meanwhile, and what is the, for example, in a case of burn injury, what is the amount of time spent by the patient inside the building which has caught fire. That would also point us towards the possibility of carbon monoxide poisoning. And if there has been ejection or extrication from the vehicle, or if there has been, the patient has been succumbed to the, as I told you, carbon monoxide poisoning, all these things are important. Then the injuries found and suspected. What injuries are you suspecting depending upon the mechanism of injury? Then the symptoms and signs, whether the patient is showing any signs of deterioration, any signs of shock, any signs of airway obstruction in the form of stridor, inability to speak or unconsciousness, or if the patient is having noisy breathing, if the patient is having signs of chest injuries. So all these things have to be analyzed and documented. Now, documentation is very, very important, especially in the current era of medico-legal litigations. And then the treatment has to be initiated then and there. If there is an airway obstruction, please intubate the patient and then go on to B, C, and D. If you have a multi-faceted team or a lot of team members who are there to assist you, then the team leader directs in a closed loop communication to the team members what each member has to do at that particular point in time. Then this ample history, AMPLE, this is another mnemonic which is used in secondary survey to be used once the mother is stabilized, to know the immediate history of the patient before the accident or injury. A stands for allergies. M for medications currently used. For example, if the patient is on, let us say, some kind of antihypertensive treatment, past illness or pregnancy. Now, this is very important. You need to know whether the patient is having any pre-existing illness, and it is said that any woman of reproductive age presenting to you in the emergency department, please rule out pregnancy. Then the last meal time. Now, this is again a very important aspect, because all the pregnant women, they are considered to be full stomach, and hence you need to be very careful regarding aspiration, prophylaxis, and the chances of aspiration, especially in an emergency scenario. Then the events or environment relating to the injury that I have already explained in my previous slides. Now, coming to this brief flowchart regarding the blunt and the penetrating abdominal trauma in pregnancy, we need to understand that the principles of ATLS remain the same in both, apart from the fact that we also have to look into the fetus and monitor the fetus and look for signs of shock or respiratory distress early, because these patients can have problems or go into shock without manifesting, and the fetal distress may be one of the first manifestations of distress in the mother. So in joint patient, the ABCD primary survey and the maternal status is assessed, and if she's stable, then you can do a secondary survey and then think about doing a radiological assessment after shielding the abdomen, and then maybe consider an obstetric ultrasound and involve the obstetrician and decide whether you need to admit and monitor the fetus. But if the patient is unstable, please stabilize, resuscitate, do the ABCDs, and then go for fetal monitoring and stabilization. Now, coming to the penetrating abdominal injury, now one thing which is very important in this is that because of the pregnant uterus, which comes up or above the level of the umbilicus, the intestines and other abdominal organs are relatively shielded. But if it is an upper abdominal injury, then they can get injured and that can lead to problems. But in these situations, in penetrating abdominal injury in pregnancy, the uterus can get severely injured, resulting in uterine rupture and placental abruption, and that can severely compromise the fetal viability. And in these patients, it is very important to prevent the lethal triad of acidosis, coagulopathy, and hypothermia. And hence, you must remember that a multifaceted, multidisciplinary approach to resuscitate the unstable mother is the most important aspect. Now, mechanisms of trauma, this I have already highlighted: blunt injury, penetrating injury, thermal injury, hazardous environment, like exposure to chemicals, toxins, and radiation is also important, and intimate partner violence. Now, one important thing about motor vehicle accidents is because of either non-use of seat belts or improper use of seat belts. So, or the mother is under the influence of intoxicants. So, all these things are important to consider. Hence, it is suggested that you need to use both a lap belt and a shoulder restraint, because usage of lap belt alone does not prevent the body of the pregnant woman from folding over her abdomen in the event of an accident, because that can increase the intra-abdominal pressure, resulting in placental shearing and abruption. So a shoulder restraint is also suggested so that the mother is safe. And this can also result in contricu injury, and that can have a lot of problems inside the uterus and lead to both maternal problems and fetal loss. So this I have already suggested in my previous slides. So the discharge criteria in a case of blunt trauma in pregnancy is depending upon the maternal condition, and then depending upon the fetal heart rate and other conditions of the patient. So the uterine contractions should have resolved. There should be a reassuring fetal heart rate. The membranes must be intact. That is, there should not be any vaginal bleeding or vaginal discharge. There should be no uterine tenderness. And all Rh negative patients should receive Rh immune globulin therapy unless the injury is remote from the uterus, that is isolated distal extremity. So this is very important. Any Rh negative mother coming up for after trauma, please remember to ask about Rh status and then giving the anti-D injection. Now, why pregnant woman is different from others is because of the anatomical and the physiological changes. As I told you, it's an intrapelvic organ till 12th week at the uterus, and by 20 weeks it comes till the umbilicus, and by 34 to 36 weeks it reaches the costal margin. And in the last 2 weeks, because of descent, the fundal descent of the fetal head engaging, it can go down. So the intestines are pushed carefully, the bowel is protected, but the uterus and the placenta become vulnerable. And if there is penetrating injury to the upper abdomen, it can result in complex intestinal injury. And it can also cause amniotic fluid embolism and DIC. One important thing which I would like to highlight is that the pubic symphysis widens in normal pregnancy. So an X-ray of the pelvis has to be interpreted in this light, because the pubic symphysis, it widens to 4 to 8 millimeters by late gestation. So one has to understand, but yes, a pelvic fracture is very deleterious in a pregnant woman. It can lead to severe shock and loss of both the mother and the fetus. Lack of placental elastic tissue makes it vulnerable to shear forces at the uteroplacental interface. And the various physiological changes are also important for us to understand, because once you do the labs in these patients, the patients may have a low hematocrit, which is normal of pregnancy. The WBC count can be raised. But if you find a normal fibrinogen level, then please think about de-icing, because in a pregnant woman in advanced gestation, the fibrinogen level rises up to 400. So we need to be very much aware of this. And the cardiac output is also increased. There is increase in plasma volume and decrease in vascular resistance, and this, the vena cava or the supine hypotension syndrome, which reduces the cardiac output by 30%. So this is another very important aspect which we must treat. In any trauma victim, we must do a left uterine displacement and prevent or treat this compression. And there can be normal ECG changes like left axis deviation, flat or inverted T waves, and ectopics. So we should not be deviated or diverted from our main goal of ABCD by these changes. Now, these are the various respiratory system parameter changes which are normal in a pregnant woman. This you can find in any of the books, but please remember that the FRC is reduced, and hence they have a greater chances of oxygen desaturation, especially in episodes of apnea. So maternal desaturation means maternal hypoxia is equivalent to fetal hypoxia, and that can lead to loss of both the mother and the fetus. So other anatomical changes are also important, especially related to the airway and the chest, and these determine how the mother responds to various injuries. But one thing which we must remember is that the mother is bound to have a low bicarbonate, 17 to 22 milliequivalents per liter, in view of hypocapnia and inherent metabolic alkalosis. So, so that is, so what happens is that because of tachypnea and increased tidal volume, the patient is having hypocapnia, that is low PCO2 levels. So in a pregnant woman, if you find, in a normal pregnant woman, if you find a PCO2 of 35 to 40 mmHg, please remember that this is not normal and it is a sign of impending respiratory failure. So that is very, very important for us to understand. The arterial pH 7.4 to 7.45, compensatory respiratory alkalosis, and diminished pulmonarism. So these are the pitfalls which I have been talking in my previous slides. Just to summarize them, we must recognize that any injured patient in the reproductive age group, female patient, can be pregnant. We should not overlook or underestimate the physiological and anatomical changes of pregnancy. These patients will have difficult airway. All pregnant women should be considered difficult airway and full stomach, and hence please call for help and arrange the difficult airway card and make sure that it is functional in your emergency room. This I just told you, PCO2 of 35 to 40 indicates respiratory failure. Now, if the patient is having a pneumothorax, remember to place the chest drain slightly higher up than usual to avoid the intra-abdominal placement of the chest tube. And if the patient is having seizures, please think about eclampsia, because pregnant women can have eclampsia if the patient is an unbooked antenatal case and not having regular blood pressure checkups. She should be considered full stomach, and all aspiration prophylaxis should be taken. And you must provide left uterine displacement, especially if the patient is in hypotension. And do not forget to administer RH immunoglobulin therapy in an RH negative mother. This I have already discussed in my previous slides. Now, maternal and fetal resuscitation, they go hand in hand, but remember the mother scores over the fetus. Log roll the patient to the left by 15 to 30 degrees. And the signs of shock will be late, and the vasopressors, they form the last resort for shock. Please identify the source of bleeding and stop it. That is what is the recommended therapy. So the main cause of fetal death is maternal shock or maternal cardiac arrest and placental abruption. So look for signs of uterine rupture and auscultation of fetal heart tones with abdominal Doppler ultrasound by 10 weeks of pregnancy, and continuous fetal monitoring is required beyond 20 weeks of gestation. So risk factors for fetal loss include maternal heart rate more than 110, injury severity score, ISS score more than 9, less than 9 is mild, 9 to 15 is moderate injury, 16 to 24 is severe, and more than or equal to 25 is profound injury. Fetal heart rate more than 160 or less than 120 is again sinister, and any history of ejection from a motor vehicle crash accident of the mother is again a very high risk thing. Now, this is something known as perimortem cesarean section. I'll just take 1 or 2 more minutes. This is performed in a traumatic arrest situation within 4 minutes of maternal cardiac arrest, when you decide that the fetus is viable and the mother could not be resuscitated. And you must realize that the fetus will present in distress even before the mother has any hemodynamic abnormality. And obstetrical code blue should be established in all major trauma centers, and emergency cesarean delivery tray sterile should be available in the emergency rooms. Now, these are, some things which may not be available in all the centers, and you must follow the ACLS guidelines for management of cardiac arrest in these patients. Of course, give left uterine displacement. Bleeding, identify and stop the source, balanced resuscitation, permissive hypotension, and preventing the lethal triad, considering the early use of blood products, tranexamic acid, calcium, and resuscitation goals are again very important to understand. Now, the various treatments which are indicated, I have already suggested. Apart from the usual ABCDE and stabilization of the mother, intubation and rapid sequence induction, please consider giving analgesia if fetal delivery is anticipated, antiemetics, antibiotics, tetanus toxoid, transfusion of CMV negative and leuko-reduced blood, RHIG, and for seizures, eclamptic seizures, magnesium sulfate, and non-eclamptic seizures, lorazepam. And last but not the least, intimate partner violence. This is very common but very least reported. And 60% they experience repeated episodes of intimate partner violence, and we are unable to diagnose or report them. And very few support centers are actually available. You must, there should be a very high index of suspicion for intimate partner violence by asking the history. Injuries inconsistent with the history, diminished self-image and depression and suicidal attempts in a pregnant woman, self-abuse and self-blame for injuries, frequent ED visits, substance abuse, and the partner insisting on being present during the history and examination. You can give a screening assessment questionnaire if you have any high suspicion, and then do the needful. So actually, I would not be able to cover such a vast topic in such a short time. So to conclude, the obstetric trauma team leader and members to be well versed with altered maternal physiology and anatomy, please follow ABCDE. The primary mission is to ensure optimal resuscitation of the mother, identify and treat the life-threatening injuries before transfer, initial assessment, resuscitation, secondary survey, assessment of the fetus, and then think about definitive transfer. Involve the obstetrician and neonatologist early. There has to be a close loop communication between the team members, and very important, that is documentation. Maintain a high index of suspicion for the presence of intimate partner violence, and please do not forget to administer RH immunoglobulin therapy and continue fetal monitoring for 6 to 24 hours, depending upon the type of injury and the maternal condition. Thank you so much for your patient listening. Thank you, sir. Thank you, ma'am. Thank you.
Thank you. Thank you very much, Dr. Uma. That was a very energetic talk on a very important topic, trauma in pregnancy. it was quite interesting. I think the gist of it is, I think, ensuring we know the mechanism of injury, so we know what to suspect, a very systematic approach of A, B, C, D, E, and not get distracted with the baby, because mother comes first. So only if we save the mother, we can have the baby. And I have a couple of questions, but before that, do any of the panel in the obstetric faculty have any questions for Dr. Uma, please? Dr. Vidya, Dr. Preeti, Pallavi, Shiv.
Uma, thanks for that very exhaustive thing. I think you did a wonderful job of covering so much in so little time. So, do you have any personal experience of dealing with obstetric trauma? If you have, what were the key things you did which you thought made the outcome good, or if it wasn't good, what do you think you should have done to make it better?
Ma'am, I do have personal experience of trauma in pregnancy, and actually the patient, she came to the emergency after a fall, and she was then brought to the theater because of non-reassuring fetal heart rate. And then the history was taken, and then later on it was found out that it was a case of intimate partner violence. The patient was saying that no, she fell down. And then later on, after the child was born, and we resuscitated the mother and then the child, and then we arranged for the neonatologist, and everything was done in such a fast manner that we were totally exhausted by the end of it. But then we counseled the mother, and since she was from a low socioeconomic background, she was not very forthcoming in her history, but yes, she did confess at the end of it after seeing her child, and she was very happy we could save her child. And I mean, that was a very gratifying experience. Yes, but yes, we couldn't document it. We couldn't document it.
Interesting. Yeah.
Thank you, Uma.
Thank you, ma'am.
There aren't any questions on the YouTube. I've been, trying to see what. There are good comments for you, Uma. I think awesome presentation.
Thank you, sir.
Very
Thank you.
informative and practical. That's from Aparna. And I think yes, there was lots to cover. And
I just
I
have
think the flowchart wasn't very clear. I think.
Yes, sir.
Yeah.
Yes, sir. I will improve it next time.
Yeah, it's very difficult to actually also see on a small screen.
Yes.
But I think flowcharts are very, very important part of any discussion. So I think.
I just have one point to raise. About the importance of tranexamic acid when we have a trauma patient. I think we have been, as the ATLS protocol has, just few changes have been made over the years. And yes, we always say, A with the C, make sure the C-spine is okay, especially if they are unconscious or drowsy, because we never know in the movement and within transfers, we can have a C-spine injury. And I think we have noticed one of that in one of our patients, because primary hospital, the patient was able to respond. But by the time she reached there, and they had a C-spine injury in the reaching hospital, and they were not able to differentiate at which point the injury happened, whether it was the trauma or the transfer. So documentation and A with the C, color becomes important, just like any other trauma patient. Common things, the missed. I think tranexamic acid for pregnancy, I think it becomes even more important. Do you think?
Yes, ma'am, because the ATLS guidelines, they specifically mention that you need to take tranexamic acid in any suspected pregnant trauma victim. More so because pregnancy is a hypercoagulable state, and these patients can bleed a lot without you even knowing.
I think it's altered physiological balance of the coagulation.
Yes.
I think it adds role. And as you highlighted, we have this permissive concept of permissive hypotension does not
yes.
pregnancy, because we start early vasopressors to avoid DNC and ARDS in trauma, although we fill them up and get blood early. In pregnancy, because of the vasodilatation, I think people have to be cautious. They still have to ensure that the circulation is filled, because early vasopressors can compromise the already compromised. I think these are the subtle differences.
Ma'am, the vasopressors, they have a deleterious effect on the uterine vasculature also. So
Correct.
what they do is they increase the uterine resistance, and that reduces the perfusion to the fetus. So the uteroplacental perfusion is also affected, and that is why vasopressors are specifically the last resort in pregnancy as compared to a non-pregnant woman.
Yeah. So a lot of fluids and blood.
Yes, blood. Yeah. Blood products also, because they are saying that early initiation of blood products is also important. Nowadays, a lot of work is being done on that also.
I think the right team, I think you should need the right team and get things going when we have a trauma patient who is also pregnant. So with regards to the timing of C-section and delivery of baby, I think it's the same as ACLS protocol.
Yes.
So within 4 minutes, especially
Yes,
yes,
4 minutes.
Yeah.
But ma'am, it is very impractical, especially in remote areas. I mean, even in smaller cities and towns, I have hardly seen equipment available for perimortem cesarean section in the emergency area. So that is something which we really need to work on.
Yes, absolutely. But I think it should be at the back of our mind that, this should be on the agenda to improve the mother's circulation, venous return, and for the better outcome of the baby as well.
Yes, ma'am. Yes.
Any other questions from the panel or should we? Yes, Shiv.
This is, I think, Dilnaz has actually just made a comment. We have done once in a cardiac arrest, resuscitation, pregnancy, and emergency extraperitoneal anesthesia under local anesthesia, as there was no time to save the baby also. I think there is no question of actually local anesthesia or general anesthesia here. You just have to open. And there was actually a case posted on the group, I think it was a month or so ago, and they did actually have a good outcome.
Yeah.
I think you're not thinking about pain here. The patient is almost dying. You just have to go. You can always think of local anesthesia once the baby is delivered. You can always think on when you have got the circulation back. That's a different thing. But I think thinking about local anesthesia and wasting time, no wasting of time here.
Yeah, I think the differences are, I think if you have a clear-cut case of major trauma or a mild trauma, we may have no problems, but it's the borderlines, blunt trauma, where we are, hovering on the corner, where all the ABG analysis and quick ultrasound would help. And I think the message should be, we should not hesitate twice about doing any X-ray. Or any just because the baby is there, because mother comes first. That's another problem, that a lot of obstetricians don't let us just move them to the CT scan. And that is something that if you're suspecting something on your fast ultrasound, we have to act on it. Or if you need a CT, we need to get them done as critical care or emergency doctors involved in the team care, even before they come to theatre. Otherwise you'll have some surprises in theatre, so which may not be very pleasant. So
and ma'am, one more thing, the X-ray exposure is not going to harm the fetus. The amount of radiation exposure in X-ray is minimal. And in a CT scan, the exposure is, in one CT scan, it is only around 25. So again, the exposure for fetal harm to occur because of radiation is again less. So one more thing is we have ultrasound. So if you don't want to do serial CT scans or serial X-rays, then you can substitute the repeat investigation with an ultrasound rather than a radiation exposure. So that is what
I think it's of importance to use the clinical acumen at that point and do the right investigation.
Yes. And investigations only if the mother is stable. Do not shift the patient to a CT room if the patient is unstable. So that is what is another take home.
Absolutely. See, the things that can get missed is when they have, like you mentioned, if there is a need for chest drain, if there is a need to ventilate. We had a patient with a fall, and it was a shoulder injury with a clavicular fracture. So they were only concentrating, and because they were hesitating to do the X-ray, but by the time the patient reached the main hospital, they had a pneumothorax. She had a pneumothorax because she was on high flow oxygen and those sort of things. I mean, that case kind of highlighted to us that X-ray, if it need to be done, has to be, and the primary treatment has to be done. So we cannot waste time. So
Can I, yes, come into? I think we need to be also be, I think, sure about the what pregnancy, what stage it is, isn't it? About X-ray exposure. Full term, it may not be a cleavy problem, but I think early pregnancy, first
Yes,
trimester,
yes,
might.
yes,
And then shielding with a
yes. Lead apron of
we can actually still use that.
absolutely.
So, yeah. So I think if you're not sure, just shield the abdomen with a shield, X-ray gown, which was available everywhere. So you should be able to do that.
Yes, sir.
I think third trimester, you should not hesitate at all.
Yeah, absolutely.
Not. It's only
Yeah.
a question of second trimester and first trimester,
First
if at all,
trimester.
that you are going to hesitate. So hopefully other injuries are easier to pick up with ultrasound in the first trimester. And also when patient has antepartum hemorrhage after trauma, it's very difficult to distinguish whether it is from the placental separation or from the trauma. So those are all the confounding factors that Uma highlighted very well.
Yeah, absolutely. Yeah.
I think that's for vanilla. Just to note, I think we need to also, I think, in one of the symposium talk about the X-ray radiation and pregnancy.
Yeah.
And importance of in our setup, every female childbearing age is actually asked whether she's pregnant or not.
Yeah.
And I've had a case, this is a few years ago, where a patient said she was sure she wasn't, but because there was a policy of doing the pregnancy test, well, one of them was missed, but later on it was introduced, pregnancy test was introduced as part of the checks. So we need to be also,
Careful in
it would be a good topic to actually include about that.
I will get that.
Shall we move on, or
Yes,
because there isn't any
Is
more
everyone
questions?
okay? I think we can move on to the
Yeah, we should. I think.
topic. Yes, and I now invite Dr. Vidya Mohan Ram, a well-known speaker, a very famous face amongst our anesthetic circle, over to a very nice topic. And I think she had a great discussion last week also, assisted reproduction and increasing age of mothers. Over to you, Dr. Vidya.
Thank you, Vanilla. Actually, when Vanilla asked what topics we could discuss in the symposium, I just put it up as something because I was recurrently anesthetizing patients in this age group. I never knew she's going to throw the ball back in my court by asking me to speak on about it. So this is much easier topic to speak than Uma. So I hope to complete it early so that we can catch up on last time. The impact of increasing age and assisted reproduction on pregnancy. So, complications associated with assisted reproduction, these are well documented. There is an increased risk of obstetric complications like pregnancy-induced hypertension, placental abnormalities like placenta previa, gestational diabetes, and it not only causes problem with the mother, it causes problem with the baby as well. So perinatal complications include prematurity, low birth weight, small for gestational age, congenital anomalies, and in the rare cases, intrauterine fetal demise. Among the assisted reproduction pregnancies, incidence of complications are higher when there is multiple pregnancies and when the mother is older. And peculiarly, the risk of gestational diabetes has been found to be higher in vitro fertilization versus intracytoplasmic sperm injection, and higher in fresh embryo transfer versus cryopreserved group. I just thought it was a peculiar thing, so I just put it there. So how are the outcomes in assisted reproduction techniques improving now? Because we've gone are the days when the headlines used to be made about 8 children, 5 children, 4 children being born. So now many countries have adopted a single embryo transfer, at the most 2. So ART associated complications are reduced by single embryo transfer by use of cryopreservation techniques, especially if the mother's already had a failed transfer. Then the next time they use cryopreserved embryo, that seems to reduce the complication rate, though the success rate may be slightly less. And the other thing which is done is early artificial reproduction therapy. Like before, people used to wait for 7 years or whatever before considering IVF. But now more and more young women who are unable to conceive, or young couples who are unable to conceive, are taking ART treatment early. And that actually has helped to reduce the incidence of complications and improve outcomes. The worrying thing is there are even reports of long-term complications like decreased school age and child development in assisted reproduction, though that's not the norm. Yeah. The other part of the talk is implications of advanced maternal age. So the problems with older mothers is that they may have pre-pregnancy comorbidities like diabetes, hypertension, hypothyroidism, obesity, which is the current new epidemic along with diabetes in India, obstructive sleep apnea, which is a much underdiagnosed and people are not even aware of it in India, whereas probably the other parts of the world it is much more recognized. Renal disease, ischemic heart disease. Again, ischemic heart disease is in much younger people in India, and even women around 40 are being diagnosed with myocardial infarctions. You can have India still has a high incidence of rheumatic heart disease, so patients who have been asymptomatic through the early years of their life, around 40 when they start decompensating, if they get pregnant, you're going to see that as well. And another thing that some of you might have come across is patients who are pregnant may also have malignancy and land up needing chemotherapy. Above all this, one of the common problems of advanced maternal age is anxiety of the mother, of the partner, and the entire family. So when an older mother gets pregnant, same thing, you might think I've just copy pasted the slide for assisted reproduction, but it's actually true for both conditions, that when mother's age is higher than 40 or 45, the chances of gestational diabetes are more, pregnancy-induced hypertensive disorders are more, including the severe forms, placenta previa, preterm delivery. Most of these women land up having to have induction of labor rather than going into labor normally, for two reasons. One is just as soon as the maturity is attained for the baby, the obstetrician prefers to deliver to avoid any late fetal loss. And they may need assistance like vacuum or forceps. Cesarean section rates are much higher in mothers who are older. And the main problem is postpartum hemorrhage. And the incidence of having to have a cesarean hysterectomy is very high compared to younger mothers. So in a sentence, if I have to say, there is an increasing risk of severe morbidity, transfusions, stroke, embolism, eclampsia, and hysterectomy as a mother's age rises. Up to 5.3% of women above 45 years might be having one of these problems, compared to much lower in those who are below 35. So when we have a combination of a mother who's older and also has a pregnancy which was assisted by technique, then what are the things we need to look at? It's the same what we do for many mothers, but in India, most of the freelancers and sometimes even in corporate hospitals, we see the patient for cesarean on the table, because you get a call saying the obstetrician decided to do a cesarean and the patient is on the table. By the time you reach the hospital, patient has come from the labor room to the OT. But here we have to be a bit more careful. So we have to look specifically for associated comorbidities, which I mentioned earlier. We all know that pregnancy is associated with difficult airway and difficult intubation, more so in older mothers. And obese mothers, you may have difficult, and older mothers, you may have difficulty in conducting a neuraxial anesthesia. So whenever you get a chance to see a mother in advance, look specifically to make sure you won't have a difficulty in giving a spinal. We know that they have higher incidence of PIH and PPH, and so we have to look for coagulation disorders, though it may not be a routine to do coagulation disorders for all pregnant mothers coming for cesarean. In this subgroup, probably you're fully justified in doing a coagulation disorder whenever there's time. And we have this strange responsibility in pre-op counseling that we have to explain all the risks and also reassure, because like I said, one of the main problems in older mothers and those who have had IVF is that they are extremely anxious. They may have had previous fetal loss, bad obstetric history. So they are already anxious, but we are in a unenviable situation of having to tell them that they have a higher risk of many complications. But at the same time, we have to reassure. So the moral is that we should look after these ladies in a proper tertiary care center, or at least in a secondary care center where we have full backup of, we should not plan and look after these ladies in low resource situations. And so intra-bris include hemodynamic fluctuations, because either you can have hypotension due to PPH, or you can have hypertension because of uncontrolled PIH. You can have airway compromise. And when you have PIH, if you have used magnesium, then we know that magnesium is a tocolytic. So we are setting ourselves up for a postpartum hemorrhage. And the single most important problem is that we have to anticipate postpartum hemorrhage. Normally, in most parts of the world, any patient who has had a cesarean probably is in recovery for a couple of hours and then goes back to the room. Most places in India, patient goes back to the ward directly from the OT. But this subset of patients, probably we should have enhanced postoperative monitoring, so that we can, if there is any postpartum hemorrhage or anything, the patient is under proper observation. So I would like, among the articles I read, though this is a little old, this is 2014, but I really found this article very useful. So I encourage any of you to take a screenshot and look at this article later. So I'll be discussing some of the points that were raised in this article. Anesthetic considerations in pregnant women at advanced maternal age. The slide is a little busy, but I have highlighted what I want to show you. So one of the important things is when mothers are above 45 years of age, more than 49% of them, meaning roughly half the mothers are actually preemies. That is one of the peculiar things that you need to see. Similarly, spontaneous pregnancy is only 35%, which means 5% of them have undergone some kind of assisted reproduction. So like I said, the combination of advanced maternal age and assisted reproduction sets us up for high probability of complications. Then in this particular group, the normal vaginal delivery was only in 30%, but in India, and especially in my hospital, probably 100% of ladies who are above 45 would be delivered via C-section. Fortunately, when they are above 45, I think even the obstetricians are a little careful, and most of them are planned and have elective cesarean. So again, in my hospital or my experience, it will be nearing 90% elective, and only 10% will come as emergency. But when you are in the 40 to 44 age group, you might have more coming up for emergency cesarean. And same thing that we discussed earlier, the problems like preeclampsia, chronic hypertension, that is pre-existing hypertension, patient magnesium therapy, diabetes, all this incidence is much higher. So more than 12% of your women above 45 years are going to have preeclampsia. Up to 25% could have pre-existing hypertension, which could get worse with PIH. And 11% would have probably needed some kind of magnesium therapy. And again, 1/4 of the patients are probably having either gestational diabetes or pre-existing diabetes. So in the middle of all this bad news, there is some good news. Is that when we talk about labor analgesia and cesarean section, it doesn't seem to be too much problem for us, because in the number of needle insertions to establish epidural anesthesia wasn't higher in patients who were above 45. Difficulty also wasn't much higher. Only about 3% patients there was difficulty in getting a spinal in, or hardly anyone needed a resighting for epidural. So no need to be too worried that when it comes to the actual brass tacks of conducting the anesthetic, we may not have too much of a problem. Then higher incidence of so other thing is, when we give all over the world, we obviously give most of these patients would receive a spinal anesthetic for cesarean section. So the peculiar thing is that a need for vasopressors during spinal anesthesia is not higher in the older women than it is for not so older women. Similarly, the need for invasive monitoring is also not very high. And like we discussed before, difficulty in establishing spinal anesthesia is also, though it seems a little high, but because of the low sample size, it's probably not significant. So one of the things postulated about not having spinal induced hypotension is in the older age group is that because we have seen in our own practice that when patients are having preeclampsia, they seem to tolerate a spinal better. So I think they kind of negate each other, and we get a good reduction in the hypertension, but not hypotension. So what is the thing that is going to be really tricky about these patients? Like I mentioned in the beginning, postpartum hemorrhage. The incidence of postpartum hemorrhage skyrockets from about 1% in patients between 40 to 44 years to about 8%, which means 8 times more chance of mother who's above 45 developing postpartum hemorrhage. So if there is one point that I would like you to remember in today's talk, it's that. And percentage of patients requiring RBC transfusion, again, obviously, because they are developing postpartum hemorrhage, the chance of them requiring transfusion is also high. And what is the tricky part? If they develop postpartum hemorrhage, it is more severe. So if you look at it here, if the patients who are 40 to 44 years old, even if they required PRBC transfusion, many of them require just one. But when it comes to above 45 age group, directly it's 3 to 4 units or 5 units is what is required. Similarly, average number of FFP, like what it means is that it is not just hemorrhage, there is coagulopathy involved. So patients who are above 45 years, when they develop PPH, they require more PRBCs and also FFPs because there is an aspect of coagulopathy. Similarly, average number of cryos used also is 10. And average number of platelets also is 6. So when an elderly mother develops postpartum hemorrhage, it is likely to rapidly deteriorate into severe PPH requiring activation of massive transfusion protocols. So going through this article, the points that I shared, what are the points to remember? That pre-op hematology and coagulation profile is a must when you are going to anesthetize an elderly mother, especially if she has had assisted reproduction. We should reserve adequate quantity of blood products. Nowadays, we don't reserve blood for regular cesarean section, but this subset of people would be the outliers, and you would be fully justified, especially you're working in a resource constrained area where you don't have immediate access to blood products. It is worth your while to make sure that adequate quantity of blood products are available before you take up this patient for cesarean section. Then availability of trained and senior specialists. Most of us are used to working solo, and especially the freelancers are probably don't even have someone they can call immediately. There may not be another anesthetist in the next 5 miles. But this subset of patients, I would strongly recommend that you make sure that you have seniors, somebody else available for help, or at least somebody who can come to help when you need. So it's not enough if just the anesthetist is trained or competent. You need a good obstetrician. You need a very good theater nurse, and because most of these babies will be either preterm or small for gestational age, or so you will need a neonatologist. If patient develops severe PPH, you may have to do some intervention radiology. So you have to make sure that they are also kept in the loop. Many obstetricians are not comfortable doing internal ligation, or they tend to panic when things go wrong. So you may need to have a friendly vascular surgeon whom you warn and keep. And of course, those who have got the luxury of having a transfusion medicine specialist, they can inform them also and keep. I do most of my cesareans with just a single 20 gauge IV cannula, but these are the patients where I will make sure that I put a larger gauge and probably 2 IV cannulas. And even if I have not started a second line, at the first hint of any postpartum hemorrhage, I will make sure that I put another large IV line. And the PPH should be aggressively prevented and managed. Normally, we are just giving 2 or 3 units of oxytocin IV, and then after that, maybe we give another 10 or not, and different points are discussed every day on our Facebook group. There is some query about how much oxytocin to give, but here we have to be prevent postpartum hemorrhage. So, and like it was discussed in the previous lecture, administration of tranexamic acid should be early. As soon as you think that PPH is there, you need not wait for more than a liter of blood to go before you give tranexamic acid. And early use of coagulation tests. If you have the luxury of using point of care coagulation test, please use it early rather than waiting for patient to go into severe PPH and coagulopathy. Early, you should activate the massive transfusion protocol early so that we can save these mothers. So after talking about, because the topic was about, assisted reproduction, and so during pregnancy, both elderly mothers and those who have had assisted reproduction may need some non-delivery procedures also. This article and up to date I found very nice. So if you want, you could take a screenshot of it and then read through it. This was you have to subscribe for up to date. You could read this. So I will be taking up only cervical encerclage because that there seems to be an epidemic of this operation in my hospital, maybe elsewhere, I don't know. So commonest operation that is done in patients who have received assisted reproduction therapy or is cervical encerclage. So for quickly, we shall go through the theoretical part. The route could be vaginal, abdominal, or laparoscopic. Fortunately, most of the time during pregnancy, it's only vaginal. But if patient has had a previous failed encerclage, then there are limited indications for abdominal approach. And most people don't do laparoscopy procedures during pregnancy. It's usually done in the patient who's planning to conceive. Then our anesthetic technique will depend on the timing of the encerclage, whether it is in early, that is just after the first trimester over, say 12 to 14 weeks, or it is later, because occasionally when they do the anomaly scan at 18 or 19 weeks, the ultrasonogram might report a bulge in the membrane, or they may report a short cervix, and then those patients may come up for a encerclage little later in pregnancy, when the physiological changes and other problems related to anesthesia during pregnancy are more profound compared to early pregnancy. And though usually it's an elective procedure, occasionally you can have an emergency where, like I said, the scan is done and the membrane is bulging, so the patient may be rushed into the rushed for a emergency encerclage. So fortunately, gone are the days when all the patients who were having encerclage used to be put on beta agonists, and we used to really struggle with severe tachycardia and palpitations, and both for patient and us before. Fortunately, now hardly anything is used, but indomethacin oral can be used, and rarely intravenous nitroglycerin may be used intraoperatively for tocilizing. And rarely the patients can come for removal of the cervical stitch which was put in. Usually it's not very common, because when they go into labor, that time in the labor room, it can be removed without needing to come to OT or any major anesthetic, some local or just like that. If the tape is seen well, they can just cut it off. But rarely, and in cesarean, they may do it at the end of the procedure after closing the abdomen. But rarely patients may come for removal before a planned induction. So the anesthetic consideration again would be pre-anesthetic assessment with special this thing to the airway. We should look at the lab investigations. Again, older mother who's had an assisted reproduction and now needs intervention during pregnancy will be terribly anxious, and she'll be really worried that something will happen to the fetus. So it's very, you need to be really compassionate and empathetic at this time. Then fasting guidelines, we all know, is the same for pregnant women as for non-pregnant. That is 6 hours for a light meal, 8 hours for a fatty meal, and 2 hours for liquids. There is no need to prolong fast mothers. I don't normally use aspiration prophylaxis for routinely, but in patients who are obese, who have got GERD, and if you are planning general anesthesia, then perhaps it is prudent to give aspiration prophylaxis with either ranitidine or famotidine, metoclopramide, or and unfortunately in India now we again don't have 0.3 molar sodium citrate. Correct me if I'm wrong. We had it in between and now it's not there, so we can't use it. But if you have access, that would be a good 0.3 molar sodium citrate would be a good idea. Then if the definitely make sure that they check the fetal heart before they start any procedure in a pregnant lady, even if it is 13 or 14 weeks. Let them use the Doppler or whatever and confirm that the baby is heartbeat is all right. And again, at the end of the procedure, you should make them confirm. If for some reason the mother has a procedure in a little later, say 20 plus weeks, then there is even a role for continuous fetal monitoring. Then the choice of anesthetic is completely dependent on patient and you and what you're comfortable with. Should I give GA? Should I give a spinal? Yes, in early pregnancy, if there are no other complications and the surgeon is very fast, there is actually no contraindication for general anesthesia. But nowadays, more and more of us are using only spinal anesthesia. But it's normally it's a daycare procedure, so it does kind of delay things, and sometimes patients may need a catheter and all that. So if you are giving general anesthesia, should you do a endotracheal tube, or is it okay to do a supraglottic airway device? So if patient doesn't have any symptoms of GERD and it is early pregnancy, then there is absolutely no contraindication to use a supraglottic airway device for anesthesia for cervical encephalopathy. But however, if the pregnancy is advanced or patient has GERD or is obese, then, or if it is, I mean, I know it's a wrong way to put it, but if it's a extremely precious baby, or if the mother is very anxious, the mother's choice is first. So the easy way is you can tell the mother that in spinal anesthesia, almost no drug reaches the baby, so there's no chance of any problem related to drugs being used. So most of them agree for a regional, and so more and more patients are having this procedure in the regional. Then position, if it is early pregnancy, it may not matter. But again, if it is near 20 weeks, then we have to remember that you can still have supine hypertension syndrome. And again, if it is an emergency cerclage where the membrane is bulging, then you may need you may not be able to give a spinal in the sitting position. You might have to do it in lateral to make sure that the membrane doesn't come out some more. And immediately after giving the spinal, you may be forced to put a steep head down, so to make sure that the membrane stays inside. And then you have to remember, then you might want to change the type of drug you use or dose you use, or at least be aware that you could get a higher level. Just to remind that you should have at least a T10 level to make sure that you have proper anesthesia for cervical encephalopathy. Just because it is being done vaginally doesn't mean that lower lumbar or sacral block is enough. You need T10 block. So post-op analgesia, normally it's not a very painful procedure, and it is better to avoid NSAIDs. So normally just oral paracetamol might suffice. And so last year, Vanilla, do I have time? Okay, then
Vidya,
the last
you just continue.
Yeah, you can continue. Yeah, you can continue and just.
The last will be the last thing I would just like to briefly mention is anesthesia for oocyte retrieval, since we are talking about ART. So again, it can be general anesthesia, it can be inhalational or total intravenous. It can be monitored anesthesia care with IV sedation, can be paracervical block with or without sedation, or non-pharmacological interventions have been tried. Actually, acupuncture is being studied quite enthusiastically these days. And a last option is actually awake. So I'll share an article with you, which really impressed me. So it's not impossible to do an awake oocyte retrieval. So there is why are we talking so much about it? Because there's no strong evidence to suggest any drug is directly harmful or contraindicated for oocyte retrieval, though most of us would not like to use nitrous oxide. And patient's choice should be respected. If patient prefers to have a general anesthesia, then we should make it as safe as possible. Or if a patient prefers to be awake, then we should respect that as well. But the main thing to remember is that comfort of the patient and obstetrician is essential to maximize the harvest of oocytes, because they have to harvest multiple oocytes. So an uncomfortable patient or an uncomfortable obstetrician is going to defeat the entire purpose, because they will not be able to harvest enough oocytes. So if the obstetrician is not experienced, sometimes it may be better to give a general anesthesia, though it's a double-edged sword. Obstetrician is not experienced, may take longer, and if you take longer, you may have to give more dose and longer anesthetic. So it's actually quite a difficult game, and I think anesthesia does have a major role to play, and the anesthesiologist does have a major role to play in the outcome of successful IVF pregnancy. So the key is to aim for a pharmacological exposure of the shortest duration and a minimal penetration to the follicular fluid, so that we can increase the success rate of IVF. And then I would like to bring this point. We have heard in the news, and we have also seen that just because it's apparently simple procedure, oocyte retrieval is being done in all kinds of places, in the dark rooms of the ultrasound room, or without any proper anesthesia machine or resuscitative equipment or whatever. Please remember, here you are dealing with an absolutely normal mother who just wishes to become pregnant. You have no right to subject her to any risk just because the obstetrician or the owner of the hospital or somebody thinks that it is okay to do a procedure anywhere. Safety of the environment is extremely important. And just because we're just putting only a needle through the vagina and taking out oocyte doesn't mean that you can do it without proper facility, which you would have for conducting any general anesthetic. Thank you for your patient listening. I just wanted to share some of the articles which I found interesting. I would call this as further reading, or some of these I have taken points from. So I like this article. Again, no longer rare diseases in obstetric. This is again a very, it was an eye-opening article for me. So, and the points that I raised during talk about oocyte retrieval and all, this is again about what are the complications associated. This is also a very nice article. Go through it, and very sort of, this is the article which says that actually awake oocyte retrieval is actually possible, and even though the mothers were older, they had a equally good success rate as with younger mothers when it was done awake. And we all think that propofol is safe, but actually it may not be as safe as we think. So please, maybe we should, like we have done for all other anesthesia, we do GARA. So perhaps that is the way to go. Even if it takes a few more extra minutes, I think we should give either a paracervical or a paraovarian block and also some minimal sedation, so that we can reduce the quantity of propofol that enters into the fluid. So this is another article, interesting article. Last but not the least, Indian Journal of Anesthesia. This is an old article, pretty well written. But the thing, this is what I was trying to say, that there's no real evidence that anything is completely contraindicated for anesthesia for IVF. Thank you, everyone. Thank you, Manila, and thank you, Shiv, for keeping the game going.
Thank you. Thank you, Dr. Vidya. That was a very interesting talk. And I think you quite took it to the depth with dealing with these women who come to procedures right from pre-pregnancy through the pregnancy for cervical encerclage or other associated procedures, and through to delivery and non-delivery procedures. Thank you. Thank you. Do we have any questions, please?
Vanilla.
Shiv, you're muted. Shiv, you're muted. Pallavi, go ahead.
Yes, Pallavi.
Yeah. Vidya ma'am, a few questions regarding the paper which you just mentioned. What was the sample size for that?
I'm sorry. Tell which paper? I'll go back to it.
The first paper where you mentioned about they have studied the various complications, and you mentioned about the good news and the bad news.
Yeah, so the 278 women between 40 and 44 years and 98 women above 45 years.
Okay. Yeah, I think the sample size is pretty low to say that probably the regional anesthetic is going to be easy in these patients, as these women generally tend to be on the higher side, or the BMI is slightly higher. And that can lead, we could have technical difficulties.
Yeah, that's what I said. It is not, it is even in that small sample size, they had increased almost 10% of patients, they had a problem in establishing spinal anesthesia. But because of the, sample size is low, it was not statistically significant. But what I meant to say is no need to be, you are never going to get a huge, even with today's, today's reality, that more and more mothers are older when they are getting pregnant, and more of them are having assisted reproduction. Even then, in a single center, you're never going to get a huge number of women above 45 who are having for delivery, because most of them are in the Western world, where anyway pregnancy, population is low, pregnancy rate is low. So I thought this was a fairly good thing, given the rarity of the, your point is fully taken. I don't want to, you can't extrapolate from that. But I just wanted to say that it's not all lost. You're not, oh my God, this lady is 45, what am I going to do? You need not be that disheartened.
Right.
That's all.
Yeah. Another point I would like to add is at our trust, what we do in because we've had so many incidences of maternal hemorrhages, which probably goes to uncontrolled, and in the, they all go on the other side of needing multiple transfusions. So our practice is to give the 5 units of bolus oxytocin, followed by an infusion of 10 units per hour. So that infusion would go on for 4 hours, and this is done in all pregnancies, be it a low risk or a high risk or multiple.
Is it 10 units over 4 hours or 10 units per hour? Because 10 units per hour seems like a steep dose. Is it 10 units per hour?
It's an infusion. So we prepare 40 units in 500 ml of normal saline, and it is given as 125 mils per hour. And this is in accordance with the RCOG guidance as well. So all the patients have this. So when you say that we deal with patients in an older age group, maybe it's a good idea to rather let them, show signs of an atonic PPH. Better to control it or snip the bud in the early stages.
Absolutely, that's the point I was trying to make, that even if you're a little lax about continuing oxytocin post-op in other patients, in these patients you must not. You must definitely use oxytocin for prophylaxis of PPH, and if you think it's even borderline, you must hit it hard. Probably go for carbotocin or whatever early, rather than wait for it to go out of control. Your point is absolutely well taken. It's just that I was normally we are just using 10 units and for other patients, not those with PPH or elderly. We give say 5 units IV and then put 10 units in infusion and run it for 4 hours. And give it.
So that's 2.5 units per hour. Okay.
But 10 have you encountered any oliguria with 10 units per hour?
No, our patients have all been doing well with the oxytocin infusion. Yeah.
Yeah. So that's the take-home point. Thank you, Pallavi.
Yeah, I completely agree. Yeah, thanks, Pallavi. Thank you for. I think that's exactly what Dr. Vidya was trying to say as well. That you should be more prophylactic, and your dosage, I think, goes with the RCOG guideline. Pallavi, thank you.
Yeah,
I think
we do have a board. Sorry, I'll just a bit more on PPH, because when PPH starts to set in, it is really a uncontrollable situation. So we have a board with the amount of amniotic fluid which is drained in the suction before we incise, after the uterus is incised. And that is mentioned by one of the runners. And then the dosage of oxytocin, the starting of oxytocin infusion, and if any other oxytocics are given, and the dose and the timing of tranexamic acid is all documented on the board for everybody to have a look, and we know what we are doing. So probably, where the centers where we're doing obstetrics routinely, this can be done as a practice.
I would actually say, Pallavi, those who are doing rarely must do it even more. Because
yeah, exactly. Yeah, I totally agree with that.
So the suction, simple thing we used to do is on the suction apparatus. Once the amniotic fluid has been removed, we quickly stick a label so that we know, okay, that much was the amniotic fluid. After that, whatever comes is blood. And then, of course, the mops and other things. And then for labor, now we have those, things done to the lady. So that's become easier. So actually, cesarean section monitoring of blood loss has become more difficult than for normal delivery. But all your points are extremely valid. They should be noted. There's no point of... especially you should know what time you're given carbotocin. Only then you know when 15 minutes are over and you have to give the next dose.
Exactly.
So if you want to follow any protocol, it has to be written so that everyone can see. Even if the lead anesthetist is distracted by something else, then
it's too easy to get distracted. Yeah.
Yes, other person can remind us, it's 15 minutes since we gave the last dose of carbotocin. Shall I give another dose? Something like that.
Yeah.
I totally agree. Point.
Yeah, photography is very widely practiced nowadays. People do all these very elaborate photo shoots, and the parents are very excited to take pictures. So that's a very big distraction. I have seen that, and people do get waylaid.
You might have a dad fainting as well. So yeah, I get your point.
Oh yeah.
Yeah. That's quite true, actually. Sometimes they don't give us space to go and actually start the infusion line for Synto. So, for point taken, Pallavi, I think that's quite a
Thank you
practice.
so much, Vanilla and Vidya, ma'am. Thank you.
So very, very true. I mean, just to make a point, what's the experience with carbetocin in such high risk? Because I've been now using in our unit carbetocin and auditing the practice, and pretty much 90% of our cases are high risk, and which IVF would be, I think, 50% of the cases, because we are quite a large IVF unit. And we after our first initial audit, we found that the carbetocin was not fairly effective because the patients have either had procholytics before or magnesium for the sake of the baby because of preterm or for whatever reason. So we have gone back to using Syntocinon for all the high-risk mothers, especially because I've had a couple of Sundays fully spent on just one mother, and we've exhausted the blood products from the lab. So what's the experience from your side, or Vidya?
We don't use carbetocin, Vanilla. So we just, so we follow the RCOG guidelines. So
Yes.
I think it's just mentioned, because what happens is the uterus will get completely devoid of the receptors. The receptors have lost sensitivity by then. And then... we'll be hitting with cannonballs rather than treating with the bullets in the initial stages.
So carbetocin is good for prophylaxis, but when you're anticipating PPH, better to use oxytocin, because you can then follow it up with an infusion, whereas your hands are tied once you've given carbetocin.
Exactly.
And also patients with cardiac disease, anyway, we don't want to give carbetocin, because if there is any problem, it will be prolonged. So net carbetocin for prophylaxis, and in patients with high risk of PPH or high risk because of cardiac problems, good old oxytocin is the best.
So we stick to the same 5-unit bolus, 40 units in the first bag, with NS, with RL on a second line, maintenance fluid. Synto goes by pump. And then after 4 hours, we assess them in the recovery. And if everything is okay, no more Synto, but they get misoprostol PV as per RCOG guideline, or they continue Synto, 2.5 ml per hour for the next overnight, and the next day morning they're reassessed, especially with IVF mothers and multiple pregnancies. That seems to prevent any blood transfusions, undue fall of BP and PPH. Within the first 24 hours in the ward, when the mother mobilizes, there is a huge, blob of blood clot, and then she faints, and then they have to call us. So all this has been prevented, and we have gone back to, we are sticking to this. In between, we tried carbetocin and Synto in the recovery, instead of the first Synto infusion. But that didn't seem to work. We ended up having hemostatic sutures and carbetocins, many doses. So we've gone back.
Buckley balloons. Do you do Buckley balloons very often?
Yeah. So that's great input. Thank you. I think Dr. Vidya highlighted the cardiac problem, and I think just one point, we will be doing cardiac in detail in the next symposium, cardiac anesthesia. Diastolic failure is something very prominent in the elderly mothers. And I see the more we do echo in these mothers, I think it's important for anesthetists and the obstetric team. As high-risk antenatal clinics we run, these mothers come to us and we get an echo before they get scheduled for IVF or whatever. So we know what their baseline is. Even though they have an EF, LV ejection fraction preserved, they still have the potential. They have diastolic dysfunction grade 1, grade 2. They still have the potential to compromise their on-table, decompensate on-table at the minutest problems, like say a little bit of PPH, a little bit of fetal tachycardia, any stress of pregnancy, hypotension, they tip over the other side. So I think you have to be a bit wary once they go beyond 45, 50. Now, we are glad that the law has come out that they cannot have ART after the age of 50, because 2 years ago, I had a 52-year-old, I think I remember discussing with Dr. Vidya the night before I went to theater with her, and it was a horrendous 24 hours with her, but she made it home, thankfully. And, so that's something to remember, and we will discuss that in the cardiac symposium with obstetrics. Any further?
Sorry, before you wrap up, just wanted to ask, you practice in a center where they practice ART very fervently. How many of these patients between the bracket of 45 to 50 or more than 40 are seen by you as well in the preoperative setting?
All of
All of them. Okay.
All of them.
Yeah, that's
And
good.
we get an ECG echo. Any doubt, we get the cardiologist to have a review as well, because invariably, a week before the LSAS, they start becoming hypertensive. In fact, just last Sunday early morning, I got called because she was scheduled for 6 a.m. and 3 a.m. in the morning, she went into acute pulmonary edema.
Okay.
That's and she was, that's the kind of patient. She was only 38, not even 45. This was multiple attempts at IVF, and this was the one successful. I mean, she made it okay, but that needed a quick action with two anesthetists, consultant anesthetists being there. So, yeah.
So
Yeah, you don't want surprises on tables. So
one of the things to do, which we are doing, is at about 36 weeks, they have a redo of all their investigations, including coagulation profile and all that. And then they see, Vanilla and I have the luxury of having, access to the patients well in advance. So we are lucky. But the people probably practicing in peripheries and elsewhere are not so lucky. I don't envy their position at all. But we get to see them in advance, and all the investigations are already there. So even if the patient comes in the middle of the night, we are kind of okay, because one of the team members has seen the patient, and the echo, again, it maybe we are overusing it, but that's a good thing to do, because term echo gives you a lot of confidence when patient is when you have to take up the patient in emergency with accelerated PIH or whatever. Yeah.
I mean, but still we get thrown into unbooked come. But I think majority of our doctors, their surgeons, we get to see. All the patients from our own surgeons, we get.
Thank you. Thank you so much.
The other problem is that many patients now are on 150 milligram aspirin, and many of them have got antiphospholipid, so they are on low molecular weight heparin and all. So unless we plan in advance, things can get quite messy, combination of all that. Yeah.
Okay, guys, I think we have got quite a few comments and a few questions on the live chat on the YouTube. First of all, I think I must say that we have crossed 200 views already. So one nurse reader has actually said hormone loaded pregnancy is associated with assisted reproduction, sorry. Yeah. So coagulation disorder and bleeding risk are very high in these patients. And I assume that's a common observation.
Yes.
Or is it not?
It is actually. I mean, they essentially don't respond much to uterotonics. So I think early uterotonics, tranexamic, and hemostatic sutures has become a common practice in our hospital, especially for multiple pregnancies.
So she has actually later on also added that prior injection of tranexamic acid helps in controlling the bleeding, and that's what you just said. Jesse Elizabeth, why do elective LSCs just because of advanced maternal age? I think that was to Vidya.
Yeah,
I mean, you did, I think, explain it.
Yeah. So the decision is not really mine, but having said that, I won't say that I do not agree with that decision. Knowing that there is, especially if the advanced maternal age plus assisted reproduction plus comorbidities of GDM and PIH, and knowing that if and when they develop PPH, it can be quite drastic. I think, and if it is it's a primey having her first baby at 45 plus, I think they are quite justified in making sure we provide the best environment for both the mother and the baby, when all the facilities and of the hospital are functioning fully, and senior people are available. It's a philosophically, it is open to debate. But I think if you are really dealing with these patients in and out like Vanilla does, you will actually agree that it's a much safer way to do it. I don't mean to brush away your question, but that's my response.
Before I proceed to other questions, I think DSP had actually asked, I think this may be another question for future symposium, is about prone positioning or prone ventilation in pregnant patients. I think worry about the pressure on the uterus and effect on fetus and uterine blood flow. I think those things, I think that can be again discussed.
We get Dilip to come and talk about.
Yeah, we can actually ask, absolutely. Okay. Then Dr. Prema Raj Gopal, she's a very senior anesthetist as part of our group. She's asked, is the incidence of the postpartum cardiomyopathy, what is the incidence in this group? Is it much higher compared to normal, or is it the same?
I don't have the numbers offhand with me, but yes, any patient who has a severe PIH is more prone for postpartum cardiomyopathy. So given that these patients, like Vanilla specifically mentioned, I forgot to talk about the echo during my talk. So thanks, Vanilla, for bringing that up. So if there is diastolic dysfunction and also PIH, then I would gather that, postpartum cardiomyopathy would be common. So if you have unexplained tachycardia or hypotension, then better to get an echo after post-operatively. When you have any doubt, better to repeat an echo to just make sure everything's all right.
See, I think we don't, like many other things, we don't actually have actual data from our Indian database,
Yep.
And very little actually from the UK and US as well. But the US recently published in the Circulation Journal specifically about the incidence of cardiac disease, acute and acute on chronic onset. And in that, they specifically said that the cardiomyopathy is increased in mothers who develop either early hypertension or already having chronic hypertension or age above 45. I think it's well documented. It's up to us. We have to start collecting data and looking at in our women. We have now identified in Tamil Nadu, our state has published data saying that we have increased onset of cardiac disease, or we have identified congenital heart diseases with valvular heart disease, and they present as cardiomyopathy during pregnancy, who are missed in the other pre-pregnancy time. So I think the data is all coming up, and we should definitely see that as a red flag, age as a red flag, and be more cautious. I think that's the message.
And another question from Dr. Prema Rajgopal, I think we have covered this, is taking X-ray okay after second trimester? I think we did mention that. That's second, third trimester.
I think if there is going to be a diagnosis made based on that X-ray, and if it is going to help the treatment of the mother, we should not hesitate to take an X-ray after second trimester. That is a no-brainer. What are the precautions we can take? Like Shiv mentioned, we can put the lead shield on the baby, and like Uma mentioned, we may try and avoid serial X-rays. I mean, it's you don't have to take one X-ray every day. Really, it is going to change the treatment. Go ahead and do it. The new X-ray machines have got very low radiation. To the extent that we can, even if it is going to make a difference in the management of an acutely ill mother, even CT scan should be done, like Uma highlighted. It's not only for trauma, even for something else. If it's going to be diagnostic, we should not deny the mother an X-ray just because of fear of causing a fetal abnormality.
Dr. Dilnaz has actually asked the carboprost. I don't know in what this thing, she just put query, why?
Preeti, I was talking about carbetocin as in some people inject it just before delivery, but I normally use, whenever I use carbetocin, I use slow IV just after the delivery of the baby. And carboprost is what I meant by repeating every 15 minutes is prostaglandin, not carbetocin. Carbetocin we don't repeat after giving once. So if I by mistake said that, I'd like to clarify. I only meant carboprost, which is when you have active PPH. If it is not getting controlled, you will be repeating every 15.
Yeah, I think that's what Dilnaz was actually, I think, trying to point out in that. Again, I think one more question about, I think it's role of midoclopramide. I think that was for prevention of aspiration with GA cases. I
don't use it routinely anymore, but definitely in patients with GERD, especially, and if you are planning general anesthesia during pregnancy, it's probably better to use metoclopramide as well as either ranitidine or famotidine, so that you have taken all the, because we don't have 0.3 molar sodium citrate, all the more better to use it.
That's true. I think traditionally, I think we used to give them injection ranitidine, midoclopramide to improve the gastric emptying and things, but I think that's again gone, and then we have actually come to just giving the 0.3 molar sodium citrate. But then, in India, I think that's not a problem. But that was actually, you need to have time for that. You can't be just giving injection ranitidine and then go ahead. It's not going to do anything.
It's
You
only
need to
for your
give-
mind. I mean, it's just one tick box thing, but this is more in the region of, suppose you're planning a cervical encerclage operation electively under general anesthesia, then this would be there.
That
Or
would
if
make more sense.
a planned cesarean where for some reason you want to give general anesthesia.
I think OAA actually suggests using, particularly obese, heavy, short,
OSA,
abdomen, where they have a high risk of aspiration, just when you give, the pressure, fundal pressure, something like that, and we are partially sedated. I mean, they suggest we do use IV medication, antiemetics preoperatively. Ultrasound, gastric ultrasound, if you find something, then you can empty it electively with an orogastric tube under local. That is something that's been suggested. I think the OAA president gave a talk about it recently also in one of the meetings. So we can discuss that in later, but something to bear in mind.
And I think that's DSP, I think, has asked about something which is, I think it's a more of a general thing, that people don't tend to give fentanyl or any analgesics other than oxygen and nitrous oxide and bit of volatile for any of these anesthesia. And his comment is that this probably is not enough.
What is it about, Shiv? What is the procedure?
It's about induction in GA cases. I mean, we tend to not use any opioids as part, but that has been a standard practice, I think, over the years.
No, I will just to be, just to be a little different. I think one of the advantages we had of thiopentone is that the longer distribution half-life. And in India, the surgeons are really fast. I mean, if the minute you have intubated, the third minute the baby's out. So even if you want to give some inhalation, nothing much is reached actually. But when I give general anesthesia for cesarean section, I actually use some nitrous oxide at least till the delivery, because I just feel that at least I've given something. And I used to, for the longest, I used to use thiopentone because of the little slower recovery. So there's less chance of patient coming out fully awake as against propofol. But when
that was opposite of that. I thought the redistribution of thiopentone is much quicker than that of propofol.
Okay, but let me get back on that. So, now
I thought. I mean, then you would actually get with the. I think the Indian anesthetics propofol would be better because you clean and drape, and then you do the induction.
Now, we have been doing that only. Even now, the obstetricians refuse to allow us to anesthetize before before they have finished getting ready. So it's literally a knife in the hand, and tube is in, and if we are experienced and I have seen the tube going in, I tell them, okay, start, so that at least little bit of the inhalation agent is still working, and then you give some nitrous oxide and turn on the inhalation little high to try and get a MAC early. But I mean, I mean, there is, when you have a neonatal service and when you have naloxone, perhaps there is absolutely nothing wrong in giving some fentanyl. And obviously, we do that when patients have PIH and all. When if we are forced to give general anesthesia, we won't be doing it without any narcotic or something to prevent the hypertension surge. But most of the times we get away, and I'm just lucky I have not had a patient report back awareness. Patients have come back for repeat cesarean and all that, and not told awareness. But yes, theoretically, it's a wrong thing to do, that you just not give enough anesthesia. It must be horrible if the mother was awake and felt the tube go in her throat or her belly being cut. If I was the person, I wouldn't like it. So that's why now we have moved on to regional. I mean, we really try to push regional anesthesia. In Chennai, when I started my practice in the 90s, it was an uphill task to make the obstetrician and the patient agree for regional. But now it's default, and so I think we're out of that. But DSP, your point is absolutely well taken, that why should we deny mother a decent anesthesia for cesarean? That is a topic for debate.
He's further asked, what about the role of ketamine? Is there an issue with use of ketamine?
Going to say that, especially in unstable mothers, the only reason, if other than fetal distress, if the GA is because the mother is unstable, then I prefer ketamine. And we have used fentanyl in otherwise patients as well, a smaller dose, like 50 just for intubation. And then you give a little bit more. And I give midazolam with the hope that there is retrospective amnesia after the baby is born. So, so as long as mother is happy.
Ketamine with propofol works really well because, you give the ketamine and as they are kind of going to sleep, you just give a little more propofol and hope that, the ketamine provides little bit of amnesia till the baby is born. Yeah, totally agree.
Okay. I think it's quite an
So
interesting
there was another comment about, I think this may be related to the weather and the storage conditions. They say DSP again says that carbetocin is heat stable, so it's actually, I think, more effective in a sense that where you may not have electricity, you may not actually, oxytocin need to be preserved on a 4 degrees and lesser.
Exactly why it was brought into India and the West, and especially during COVID, where transportation and things were very difficult. Carbetocin became very famous. I think that's still the only reason why a lot of the peripheral centers have, if they don't have the ice boxes and things like that to store. But as I said, in high-risk patients, we are okay with low-risk mothers. They, in fact, use it in the labor room for low-risk mothers as a regular basis. That's following our audit that we don't use them in high-risk mothers. And that's RCOG agrees to that as well. WHO strongly promotes use of carbetocin in the primary health centers and it's heat stable. So it's not out of the box, but it's something to be remembered in high-risk mothers. Would you agree? I mean, Dr. Vidya? Yeah.
Yeah, there is no need to go overboard on carbetocin. And like I said, these mothers should not be having their cesareans in the periphery. Hopefully, they should have been picked up as high risk, and when they need intervention, they should be in a better environment where all the options are available. But yeah, carbetocin was brought in because in sub-Saharan Africa, tranexamic acid and carbetocin saved a lot of lives. So that's where we are.
Ma'am, do you think that the carbetocin will have a role in pregnant trauma patients?
No.
You need to have the receptors, in labor. You mean to say for C-section in trauma?
Yes. For emergency CS, for example, a trauma patient has come and maybe taken up for CS due to whatever reason.
I think overall, I think we will stick to Synto for now. In
extreme tachycardia, perhaps carbetocin makes you feel a little better because the heart rate go up so much. But
yes.
And then if you have got 100 other things to do, that time instead of running a syntocin infusion in a polytrauma when you're busy, the carbetocin. Actually, another thing some of the obstetricians are doing is that they're asking us to give a small dose IV syntocinon and then give IM carbetocin, so that this immediate post-op 4 hours, which you need to continue infusion, can be avoided, especially in low-risk mothers. Another thing you can do, syntocinon IV to make it quickly act, and then you give carbetocin IM, so that next 4 hours, instead of running a drip for 4 hours of oxytocin, you can give carbetocin IM. I mean, these are all permutation combinations which are being tried out by different obstetricians, and when it has some scientific merit, I also go along with it.
Thank you.
Vidya, may I add my experience here with carbetocin as well?
Yes, absolutely.
Yeah, my ops colleagues would probably throw a fit if we spoke about carbetocin and syntocinon in the same patient. Their logic is they have the same receptor. So if you're going to block it with the syntocinon, you might as well continue with the syntocinon. There's no point adding carbetocin to the grind. And those who have used carbetocin will find that the uterus becomes, practically stone hard. It contracts so well that you don't really need much else. And if you really need much else, then you jump over to methergin or carboprost or something else. So we in Mumbai, we tend not to mix up carbetocin and syntocinon here.
Syntocinon, when you use a small dose, because the effect is wearing off, and when the effect is wearing off, you are giving a IM carbetocin, which onset is going to be slow. So they are not competing for the same receptors. They are going to use the receptors that have been vacated by syntocinon. I mean, not back-to-back makes no sense.
Correct. That's the point I wanted to make. Giving them together and expecting the same response will not help. When one is wearing off, the other one is going to.
So we give syntocinon IV while delivering the baby. And
Correct.
usually in 20 minutes, the surgery is over. So when the patient is being shifted out of OT after cleaning and turning and all, that time they give IM carboprostate, which I think kind of makes pharmacological sense. But I'm not advocating that. I'm just saying that these are all the things that are being tried out. Shiv, you're muted.
Yeah, so I think
We can actually end with this, and then go move on to the next.
Looks like all the interesting cases are getting discussed now itself.
Oh yeah. Yeah, so over to Vanilla for the two cases. Will be, I mean, not two cases, but
Yes,
two
I
of our
think,
faculty are going to present the cases.
Yes, over to Dr. Preeti Shenoy. Preeti always has some interesting cases with her wide experience, and she was the first to say she would go. And followed by Preeti, we have Dr. Priya Anand to present her interesting case. So first, Dr. Preeti.
Yeah, am I audible and visible?
Yes, Preeti.
Okay, thank you. Now, with such formidable speakers like Dr. Uma and Dr. Vidya, who have told us exactly what we can expect and how we can manage difficult cases in their beautiful tertiary big setups with adequate infrastructure. Now it's the turn of the poor anesthetist who has been doing rural practice for a long time before now she's joined into mainstream practice in a city. This is a case I did long back, maybe around 15 to 18 years ago in a completely rural place. And before I start, let me just say thank you to the GAS team and Dr. Shiv sir, Dr. Vanilla for putting together such a beautiful symposium today. And let me see how I measure up to these stalwarts who have already spoken. Yeah. Okay. Now my case is just an emergency LSCS from the sounds of it. It wasn't a planned one. We had a female who was 46 years old. In rural practice, it's more of an emotional practice rather than, the way you have standardized practice in cities, tertiary cities with great setups. So it's like, small towns, everybody knows each other, and most often you keep bumping into the same patients in your line of practice. So this was a woman who was married and had a cesarean section 12 years ago with no issues, no problems. Subsequently, she had some falling out, husband left her, she was left with a kid, remarried, had a second LSCS about 6 years back. And when she got pregnant for the third time, she decided to go in for an MTP with a TL in a camp where it is done under TIVA, where the surgeons themselves administer the anesthesia that is given to the patient, either intravenously or usually intramuscularly. No issues. Now, after that happened, there was some falling out with the first husband who took away his child, and she lost her second baby to a swimming accident. So that completely drove her crazy, and she turned up again on our table for a TL cannulation, which was again done 3.5 years back under GA. And that was again not a problem. Subsequently, she came within a year for a ruptured ectopic pregnancy about 2 years later. And at that time, we had done it under GA. She did require a lot of blood transfusion for that particular surgery. Now, the plan for this patient by the obstetrician, she was posted for an elective, LSCS at 36 to 37 weeks at a tertiary institute in Mumbai city. She was following up with the obstetricians at that said institute. And she was around 138 kilos with controlled diabetes and PIH on oral drugs. She did have a little bit of dyspnea on exertion, and she was AB negative. That's it. But she decides to visit us at 32 weeks at around 8:30 in the night on a rainy evening with lots of winds. I think this was during one of the cyclones at that time, with significant bleeding PV and a loss of fetal movements. Her heart rate at that time was 106. SpO2 was 100% on room air. A blood pressure of 150 by 84, which was okay considering she was scared. Respiratory and cardiac parameters were normal, and a fetal heart of 110 beats per minute. Now here the obstetrician decided that the fetus is going into distress and the mother is bleeding significantly. So we were faced with a dilemma. Since the mother was stable, the questions were whether to operate at the said nursing home or to transfer her to an institute. It was raining very badly. There could be a lot of traffic. In those days, at that point in time, the only bridge that connected, central Mumbai to our little town on the outskirts of Mumbai had developed a crack, and there was a lot of renovation work happening on the bridge. So traffic was always backed up. So there was no limits on how long it would take for this patient to reach Mumbai city. Again, the question of blood products in a small setup or in a small rural area was another big question. Limited resources where continuous running water and electricity are not your best friends. And the most important question was, what if she deteriorates along the way? There would be nothing and nobody to help us all, along with the rain gods showering themselves, all through. So with all these questions in mind, we had a talk with the patient and the relatives, attendants, and it was decided to manage the patient in the same hospital. Now, the scenario that we faced, we had a patient in preterm labor. She had started off with a few contractions by then, who was in antepartum hemorrhage, who had a history of multiple surgeries. She had gestational diabetes, PIH, which were both controlled. And she was obese with slight dyspnea on exertion for an emergent cesarean section. Luckily, she was due for follow-up the next day. So on that same morning, she had her blood works done, which showed a hemoglobin of 8.7 grams. Her lower total leukocytic count was 18,000. Platelets were at 72. The last platelet count she had done was around 74 or 75,000. That was done about a month back. And her urine albumin was positive. Now, pre-operatively, what I got to do after, before I reached, when I got the phone call, all I said was start oxygen, get a good peripheral line with an RL running. We gave her tranexamic acid, the antibiotic. In those days, we used Rantac, 150 milligrams, and ondansetron. A high-risk consent was taken. Blood bank confirmed 2 units of packed RBCs of AB negative, and they also had 2 units of O negative in case we needed, and 4 units each of FFPs as well as platelets. The hospital had recently acquired a new defibrillator and they wanted to show off. So they said, Madam, defib is also available. I could manage to call for help, and my colleague anesthetist promised to reach within the next 20 minutes after finishing his case. I'm very supremely thankful to him. And the procedure started under spinal anesthesia with a difficult airway cart ready. So we had no problem. Patient was stable. Baby was, just having 100 beats per minute. So we said we'll do it under spinal. We have a tendency of doing things under regional in the periphery. Now, the course of the case, simple spinal anesthetic with standard bupivacaine heavy, 10 milligrams, and buprenorphine, 13 mics, very, very small doses added. There were a lot of intraperitoneal additions, but having good obstetrician is again a boon, which few of us are lucky to have. The operating time was around 2 hours. Blood loss did not require immediate products. So we asked them to hold on because we came to know that there was another patient who could be possibly requiring the blood products. So when 2 patients are waiting and there are just 2 units, we tend to, hold on. So we gave her colloids and she was all right. The patient was stable, dressings were done. And the whole team, all of us went out for the customary chai while the staff nurses were cleaning the patient. Now see how things happen. Post-operatively, the patient took some time to come out. That's the way we tend to spend our post-op time. Just sit and have chai while the patient comes out. And once the patient is out, they're stable and then we can go in. Since the patient took time to come out, we went in. The staff was doing vaginal mopping and it kept on throwing fresh blood. The uterus was soft at the fundus and more fundal pressure just yielded more blood. Now we were in PPH. This was an all hands on deck situation. My second anesthesiologist friend who had gone home to sleep at around 11 or 11:15 or so was recalled back. In the meanwhile, we got 2 more people to join us, another obstetrician and a general surgeon called in for help. The blood products which we had asked to, de-reserve were again asked for immediately. Whatever else was available had to be asked for. In those days, we gave pitocin, methergin, and prostaglandin. These were all repeated. Patient had a little bit of tachycardia. BP was around, 100 systolic or so. She had started going bad. Relatives were informed. A consent of re-exploration was taken. The we cannulated the external jugular vein on the right side, because at that point in time, rather than looking out for a peripheral vein or fighting for an EJV seemed the most logical response, and we started her on colloids. At this point in time, we were ready for a complete general endotracheal induction for this particular patient. Endotracheal passed with routine, as madam said. We start off with the pento and scoline at that point in time. Ryle's tube was passed, whatever else was there in the stomach was aspirated. The procedure began, and the moment the peritoneum was opened, we were looking at a Cuvier uterus. So now again, a diagnosis of PPH was confirmed, and a consent for an obstetric hysterectomy was done. The 2 units of AB negative that we had were called in, and we also received 2 units of O negative blood, 4 units of FFPs and platelets. Now at this point in time, the BP started going down, the heart rate started going up. We pumped her full of crystalloids, colloids. It was difficult maintaining her vitals. Patient went into full-blown DIC, cardiac arrest thereafter. We did get to use the first patient for defibrillation. We gave her all the fluids that we could, all the colloids, whatever was available. I think we ended up giving her around 4 units of packed RBCs and around 8 units of FFPs and 6 units of platelets. ACLS protocols were actually followed, and we lost this patient to blood loss. Now, this is one of those patients who actually haunts me to date. I still have a lot of regrets about what went wrong and how we could manage this patient better. The questions I keep asking myself: were we wrong in taking this patient up on that night when it was raining? Should we have transferred her to a better institute instead? Which was, again, we never know whether it was a couple of hours or maybe more away. Could we have done something more for this patient? Could we have improved our facilities or our responses for this particular patient? And we did end up having around 5 to 6 blood banks in the area after this particular case. So my, what do I say? I did not have any good facilities or better infrastructure in a rural place where electricity is a problem or running water is a problem, or, we are fighting the elements as well as fighting against our limited resources. So I'm absolutely open to all kinds of constructive criticism, and I'm actually looking forward for help from everyone on this platform to help improve our maternal mortality rates or our maternal conditions in rural India. Thank you very much.
Thank you, Dr. Preeti, for sharing with us this quite a case it is, isn't it? I mean, when you go through all the emotions with this patient that you have known for quite some time, and you also go through, what is said is a nightmare to an anesthetist and an obstetrician on table, and you know this could happen, and you've done everything you could to prevent it, and it still goes on to go. So early DIC as a cause, DIC which is not responding to treatment is the worst nightmare we could face in obstetric data. Thanks for sharing. I mean, I think from what you have presented, it looks like everything was done. The surgeon was called early. Whether hysterectomy could have been done a little bit earlier, I mean, I'm not sure. I mean, whoever was in theater could have only took that decision. But setting up of early DIC with high-risk factors is something that's we've been warned about. I think if you look at the maternal mortality and prevention of DIC, and the fibrinogen degradation products early, I think, and tranexamic acid, I think these were the 2 things that the Shimru Wales project came up and presented the article in 2020. It was a Welsh audit of PPH and maternal mortality that they had in 2 patients. One was the DIC mother and 2 was the DIC due to abruption. I think these were the 2 cases where they thought that early fibrinogen degradation products and early tranexamic acid and hysterectomy could actually turn the patient to your favorable side. I think that's the protocol that Liverpool Women's also follows. these are chemical products that are available. We can have them, but again, it's expensive. We are talking about the high end as opposed to factor 7A compared to what you can do realistically in every obstetric unit. It can happen to us as well. And it has happened in close by city units as well. I have lost one of my very close relative to PPH in the recovery room, where she was about to be shifted to the ward. This happened about 10 years ago. So I think I would like input from Dr. Vidya. Dr. Vidya, you muted.
Yeah. So, Pallavi, thanks for sharing that real emotional roller coaster ride. What do you think is different today than 18 years ago in that same place? If you were to go back there, what is different now?
Well, currently we have a good tertiary setup in that area. And that is one. A lot of blood banks have opened up. So again, availability of blood and blood products is not a problem. People of that area have really gotten together and invested their time and money and sweat and efforts into improving the infrastructure in that area. That is from our side. And from the government side, the roads towards Mumbai and back are definitely much better than they were around 15 years back. That single road that was there is now a little better. And yeah, I think, see, we did give the tranexamic acid. We did anticipate issues in the patient. We were ready with the difficult airway cart and aspiration prophylaxis and blood loss and everything. We did prepare for that. We were ready for any eventuality. We did call out for help, and help was available. See, since it was in the middle of the night, everybody was done with their, OPDs and whatever daily commitments were there. So middle of the night was not a problem. So we did get people around. We did have the manpower. We did do everything that we could. But somehow I still feel that we have, possibly failed this patient. The only thing that hurts me is, should we have transferred her? Would that be a better thing to do? But then again, the question of whether she would have reached the hospital or not is something that's, sort of off-putting.
I think Pallavi wants to say something. Go ahead, Pallavi. Unmuted.
Preeti, I think this is classically a case of where the system has failed.
Can't hear you well, Pallavi. Your audio is poor.
Can you hear me now?
Better.
Better. Okay. So I think, Preeti, this case is clearly, if you see the medical side of it, is really managed the way it should have been. It's the system has failed us. Because I think you're just practically practicing in an area where the resources are very poor. You have probably not very good access to the blood bank. Your blood products came in late and probably not in the time when you should have given. Because once the PPH sets in, it's really hard to, control it. Do you think that this patient would have waited for the surgery if the patient would have been transferred?
The problem here was, once we send the patient away, nothing actually is in our hands. As in, we do not really know whether the patient will reach the next tertiary institute.
Yeah.
Or it was the height of monsoons. There was a cyclone going on. Traffic itself was a problem. Road access was an issue. Like today, if such a thing happens, I know point blank, I will say, let us shift the patient. I will sit with the patient in the ambulance and manage. Probably take the blood products with me and move myself with the patient. But back then, I don't know. I really didn't think of, taking the patient to Mumbai and, actually sitting with the patient. Today, I know I'll take a ride in the ambulance.
If I can just get in, Preeti, I think what you did is you owned the situation. You and your team took responsibility. It was not a rash decision. You considered all the options, and then you decided the risk of transporting. In the interest of the patient's safety, you decided that transporting carried a higher risk than managing her there. So I don't think you should second guess yourself about that decision at all. So, like you said, things have improved. Do you think now they have point of care coagulation tests there?
A TAG, I don't think is still available.
Something like that might be a game changer at this point, because and the other thing is, that shifting part. I mean, I am still old school. I don't leave the theater till the patient is shifted, because very often the drama happens at that time, just when we think everything is all right, and everyone, because many times, in fact, I've had the surgeon leave the operation theater before patient wakes up from general anesthesia after cesarean in the middle of the night. So in the middle of the night, it's just you. So you have to look after obstetric complications as well as, whatever else, the infrastructure, patient falling off, like we discussed. So yeah, so if I were to pinpoint one thing I would do differently, I would say that I will postpone the chai till I have the patient in the recovery room.
I've never had chai after that. I've never had a patient on table after that. I mean, last 18 years, I doubt even a DNC patient, I go out of the theater with the patient, speak to the relatives, and then think about chai and bathroom. So that was a lesson.
I don't think, I think you did exceptionally well given the circumstances, and decision making, there was never a delay, right? I mean, everything, you realize the patient has not come out of the OT, what's wrong, you've gone and checked, you didn't go home. Immediately you assembled the team, immediately you have gotten ready to open up the patient, you already had some blood in hand, you just had to this thing.
Yes.
In your place, I don't think I could have done anything different except maybe take blood in a test tube and see for whether it's clotting. So that gives you a little early idea. Yeah. So there you go. I mean, Vanilla, you were 18 years ago, you'd have done anything different. Just put on the switch on your mic, please.
No, I think given the time, situation, and how it went on, and you've done everything as per the guidelines, I think early hysterectomy is what is being advised anyway. So I think if you prevent blood loss and prevent DIC to set in, but once the DIC is set in, I think even if they are in the best of the ICUs, it's often not very fruitful, because I think the pregnancy related DICs, PPH related DIC, and amniotic fluid embolism related DICs are very, very high risk for mortality. And I have personally seen that as well. So I think I would not, I think it's something that gives us a lot of lessons, but sadly, I think we have to move on. I mean, just one thing, regarding the hysterectomy, I think that is a decision that a lot of people dilly-dally on and wait. Just to quote a similar age patient, she was a similar scenario where she'd lost the baby, so came back at the age of 48, did a section. She was also on sustained. She was a gynecologist herself, so she kept taking tocolytics at home, which was not advised. So on table, they did section, we put on Synto infusion. This was maybe 5 years ago, before the carbetocin and carboprost was given. The shifted from theater table to the stretcher. On the path slide, we noticed a huge bout of blood, and she just collapsed. She just went unconscious at that time. She had to be intubated. Surgeon called back from OP. She was in the next door building. We had to do emergency hysterectomy because there was no time for ligation, blah, blah. It was just a floppy uterus, and the baby was doing fine. So we took consent from the husband, and he proceeded with hysterectomy because we had to already pour in 4 units of blood. It was not at all responding. So that way she was saved, but that was like a decision made within the first 5 minutes, because 2 surgeons were called in. The one who did the section plus an experienced HOD was brought in, and they just decided within 5 minutes that we will do the hysterectomy, because otherwise we lose her. That's just thankfully went well, but not all cases will go in way. So hoping that we will fine tune ourselves more for early decision making. I think that matters.
Sometimes we have to nudge them along, because in that sense, when it comes to the uterus, the obstetrician is too close to the organ. So we are one step back. And the other thing I wanted to tell Preeti is covalent uterus is extremely rare. So it's not like you lost a normal atonic PPH, you lost a covalent uterus. So that's a different, completely different ball game. So I think you should stop, beating yourself up about it. You did your best, and I don't think anyone here, Shiv, will wait for your comments. Anyone else could have done anything better than what Preeti did that night 18 years ago.
Another thing I'm lucky is that all this happened in the night. Generally for us private practitioners in a rural area, there are very few anesthetists and too many hospitals, so too many patients. So in the daytime, there was a trend in that area. So whenever closure is going on, especially we had, I used to do like 12 or 13 sections per day. That was my kind of practice. I was complete obstetric anesthetist there. So it was like during closure, the next person calls up and, there's an emergency section, or I have a meconium stain fluid, or I cannot get the fetal pulses or something like that. So it was very normal and natural for us to leave after the peritoneal suturing was over. So we didn't even used to wait for the rectus sheath to be closed. Now, 4 or 5 years into my practice, getting that kind of maturity where you know that you have to wait till the patient is out of the theater. I think this is the case that made me believe in that, because that was a time when all of us were just rushing from one theater to the other. So had it been a day case, probably even I would have disappeared from the theater to go to somebody else's place. So that is another very, very important take-home point. Money is not important. Life is more important to us. We get paid very little in the periphery, a minuscule amount, but nothing can actually replace the life that you're losing. That's the point I want to make to our younger colleagues over here in rural practice.
It was not just money, it's just that there was no other anesthetist for that patient also.
Absolutely. I would never have had the friend.
Now, of course, there are probably anesthetists, a reasonably good number of anesthetists. So, Shiv, you wanted to say something?
No, it's, I think the first thing I'll tell about the comment is about, I think, Vanilla, I think you meant fibrinogen, not fibrinogen degradation products. You kept saying FDP. It's fibrinogen, level of fibrinogen is very, very important. And that's what has come from the study from the women's study, that fibrinogen levels need to be maintained around 100. Normal are between 2 to 4 gram per liter. And you have to maintain it around 1 gram or 100 milligram per deciliter. In anywhere it starts going below 100, then you need to actually give fibrinogen. And I think in such cases where the patient is bleeding and you have done hysterectomy and patient still, I think fibrinogen is the main culprit. Low fibrinogen levels are obviously it may not be easily available. Then the only thing where you can get fibrinogen is by cryoprecipitate. Yeah. So that was that. There were a few comments on the live chat. Vandana asking, 15 years back, tranexamic acid was available. It has been available for ages. Yes. Tranexamic acid is not a new drug.
Actually, we used to laugh because there are some obstetricians used to use it for hysterectomy and for every cesarean, and also 20 or 25 years back when visiting obstetrician I used to look at them like that. Just like 20 years back, we looked skeptically at those who use supraglottic airway devices. So, times change and evidence builds, and fortunately, tranexamic acid was always there. That's why it's cheap and easily available, because it's an old drug.
Exactly. It's not a costly drug. It's been available for ages, rural area, or it doesn't matter. It has been available for a long time.
If I may just butt in here, in the periphery, the problem is you're always fighting for resources. So drugs are the only things that we have in hand. So it was our standard protocol in that place, tranexamic acid to be given pre-operatively before, when you get the consent for C-section or when you decide a C-section, that is when the tranexamic acid is given. At the moment the baby is out, your Pitocin is loaded, the Mithergin is loaded, and the Prostadin is already loaded and labeled. So Pitocin goes into the bind, starts running, Mithergin intramuscular or intravenous. Some people used to like giving it intravenous, and Prostadin 250 mics intramuscular was given for each and every patient. That was protocol in the area without any thoughts, unless patient was asthmatic. Now, even for a DNC, when patients were either primies or previous LSCs, there was a protocol of giving Prostadin intramuscular before. Now, I've had some, I don't know what to call them, but some colleagues who used to give Derifilin on one butt and Prostadin on the other one, just because they wanted to use Prostadin for that particular patient. So we used drugs very liberally back then because we could not handle PPH and we didn't have resources.
So actually the clock has come full circle, and RCOG guidelines now are asking you to thank the patient with, say, oxytocin just to prevent PPH, because even when you have all the resources, the mother can still die of obstetric hemorrhage. So the people in the periphery were wise.
And I remember rates were not very high. We used to manage these patients very well. Now, this was just one place where I felt my hands were tied, and actually I was totally tied from head to toe. And I just keep wondering if I could do something better for her.
And that premise is not your problem. You manage it well. It's an obstetric thing, but obviously it's a teamwork. When patient has hemorrhage, that everybody actually comes, or you activate every resource you have, available resource you have, and patients do die. Even in the most modern countries, patients are still dying of hemorrhage. So don't think that you did your best in your limited resources, and I don't think there is anything else we could actually have done differently. If you have to take the modern, whatever advances we have, like I said, it's a fibrinogen, which is actually very important. But it's no point. I mean, the women's and other centers, big centers, they tend to use TEG, which will tell you that if this is a low fibrinogen level. And that has been a common finding. That's the thing. There's been a common finding where patients bleed, it is fibrinogen. Okay, it's not FFP you
when
need.
it doesn't respond to normal transfusion, you are fully justified in using fibrinogen, even if you cannot get a fibrinogen level immediately.
Absolutely, absolutely.
Yeah.
Women normally pregnancy, actually, fibrinogen levels does increase. That is a normal thing to happen, but when
That
patients
protects,
are
but when that gets depleted, the mother just goes down a steep precipice.
absolutely, absolutely.
Just to add, I think the cost, it is increasingly available in the city and it has a long shelf life. It costs something like 10,000 rupees and it's not like, not amenable or not, available for us. So I think that's something that people who work in the periphery can store in their hospitals or store it in their bag for use. And it is, now we have made it available. And I mean, after the, audit came out in the OAE a couple of years ago, that's something maybe people can think about for their practice. If TEG is not available, I think with the first blood sample that you take in as you wheel in the patient or put the cannula in, I think fibrinogen should be one of the first things in that package. When you send hemoglobin, platelet, fibrinogen must be the other one. So if you already know it is not in the normal level or, the increased level that she should be having as a pregnant woman, anyway, by the time the report comes 30 minutes later, you're way gone beyond. And if you're seeing signs of DIC, it should be given. I think this is what we advocate now. I think hopefully we don't have to use it ever and we don't have to face such DICs, but if come, maybe we will be empowered to use it.
They're a lot cheaper than factor 7, recombinant factor 7A, which people are using left and right. This is evidence and this is going to save lives. And
FFP only gives ARDS is the more proof we have.
FFP should not be used.
FFP, minimal use of FFP, more use of more RBCs and whole blood. And if need be, I think unless your APTT is prolonged, I think FFP is not indicated. So I think we'll talk in PIH again, PPH once again. But thanks, Preeti, for sharing this wonderful case. And we hope that we don't have to face such situations again.
Yeah, before I think we move on to the next case, I think there are a few more comments and I think that's so one of the guys, Raja, has said that arterial blood gas would be available in tertiary centers and inotropic support would have made difference retrospectively speaking. Well, I think it was not about hemodynamic instability as such. It was more of patient bleeding and then going to kind of DIC.
We're talking about a time and place where there was, by 7 p.m., all the labs would be shut for the night and they would come back at 7 a.m. the next morning. So middle of the night, if you have a test, God save you. So nothing.
Don't worry about that. Yeah, I think, like I said, it's more of you need to actually, if you're looking at one test, you're looking at fibrinogen level in these patients. And I think the take-home message should be that it need to be more than 100 milligram per deciliter or 1 gram per liter. That is the value you need looking for. Okay, 1. And Dr. Vasanthi, definitely checking clotting even in the old method of collecting blood in a test tube will help. It's also time to tell the obstetrician not to leave till we shift the patient. Usually surgeons complain anesthetists leave early. Here it is the other way around.
Correct.
Okay, and very nice presentation, Preeti. That's from Dr. Vasanthi. Dr. Premas, the early decision for subtotal hysterectomy should have been taken. We have done many. I think she did also mention that why it wasn't like internal iliac ligation. I think that's more, I think it's done when.
I don't think it helps. I mean,
I think if you're doing hysterectomy, you're not actually, Vandana says, especially vaginal mopping, we need to see. We have had 2 patients who had fresh bleeding and we had to stay back. I think, obviously, I think that's it. And Dr. Vasanthi has again said that we used methogen even intrauterine. I don't know if it really worked. Maybe it did.
Yes.
Factor 7, DSP says factor 7 cost is 45,000. It has no role in PPH in this patient. So those who are using, I think they need to stop. And I think there's a cheaper and better thing. I won't say cheaper, but I would say relative to that, compared to that, something which is not required and which is actually more useful is fibrinogen. So fibrinogen, Vanilla said, it's only 10,000 rupees. It's actually a better. So if you actually have to spend, don't go by factor 7. And Dr. Wasan say, when there is massive hemorrhage, it is still good to use fresh whole blood, but that again, it's availability. Modern blood banks do not have whole fresh blood. They will have blood products. And if I have to say that, then if there's a coagulation is a problem, then you ask for cryo rather than actually FFP. Don't use FFP. You might actually get into more trouble. Okay. So let's move on to, I think it's past half 2. So it's going to be nearly 7 o'clock, 10 to 7 in India. We have one more case, or is Priyanka here?
She's there.
And we already have crossed 250 views, so it's been good. It's 286 actually. Priyanka has got logged out again. Shall we leave that for the another time then?
Yeah, I'm just trying to reach
okay.
her.
Yeah. It's fine. It's okay. She's not logged in, so we can't. What we can actually now do is that the rest of the faculty can come in. You can have, this is the last 10 minutes for Q&A. So you have any questions or anything, we can. Dr. Vivek Kamath has said, nice presentation, Dr. Preeti. The DSP says subtotal, his cesarean hysterectomy useless in case of central placenta previa. That's true, actually.
I mentioned factor 7 only to condemn it, not to.
Yeah, absolutely.
It's
absolutely.
more expensive, and so it's worthwhile investing in fibrinogen rather than.
Exactly. Absolutely. I think you're 100% right. I mean, I can actually, I can tell one of my experiences as a registrar. I was posted in the women's hospital as a senior registrar, and it was Friday afternoon. We had a patient, and this was multiple pregnancies. I mean, multiple in the sense that she is multipara. And I did ask them, I said, do you know where the placenta is? Whether it's in the scar, sometimes you bleed. That's one thing which should be mentioned. It wasn't. Anyway, they said, no, the patient had a spinal anesthesia. The baby was delivered, and they were trying to, I think, close the uterus. And I was seeing that the patient was requiring more and more fluids and vasopressor to maintain the blood pressure. And they were about to close the abdomen, and I said, no, you cannot. I said, there's something not right, and you need to look at something. This patient is requiring more and more vasopressor. And I actually sent for, this was, I think, a registrar, senior registrar operating, or some senior fellow operating on the patient. And I say that they need to get the consultant in. I actually also called for help. And the consultant obstetrician came in, was like, oh, what the hell did you call types? Or get me that long needle. We need to give intrauterine, thing, whatever. I don't know what they were planning to give, whatever. They gave, nothing happened. Okay. And to cut the story short, the patient actually ended up with a hysterectomy. Okay. The consultant came. Vanilla knows him. Phil Barclay was the only consultant. That he came in, and the patient ended up getting transferred to the other center, which is the Royal Liverpool. Next, the patient got transferred there, went to the ITU, and as soon as the patient went to the ITU, again dropped the blood pressure, ended up in theater again. Laparotomy done, and again, and patient did really well. And in this case, it was postpartum hemorrhage. It wasn't. They tried to actually present the case as amniotic fluid embolism. That's how it was presented. I wasn't even called for the grand round, but this was presented amniotic fluid embolism. Amniotic fluid embolism has got very high mortality. I mean, even if that happened, we saved the patient, even if they think there was. But I think this was simple, plain, PPH. So
if I can just butt in, Shiv, one of
Yeah.
the things I'm habituated to do is to always look at the ultrasound. I mean,
Yeah.
sometimes even
I
obstetricians.
asked them.
I don't know why, but it's very difficult to get even my colleagues to look at the investigations related to the surgery. Like
Yeah.
everyone's happy to look at the blood test and ECG and echo and whatever it is. They think that anesthesia is separate from surgery. Unfortunately, not. So if it's a ureteric calculus for URS, it makes sense to know, is it upper ureter, middle ureter, or is it a vesicoureteric junction? If it is a fibroid uterus, is it a 20-week uterus size fibroid, or is it a 5-centimeter fibroid? So I think I would like to get this message across to all the juniors who are logged in, that please, anesthesia most of the time is or almost always is non-therapeutic. We are only facilitating the surgery. So we need to know as much about the surgery as to give the appropriate anesthesia and watching the surgery, because she watched the operation, because he kept a track on the blood pressure. That is why he could pick up BPH, which the obstetrician could not, or whatever. So in the end of the day, when in the OT patient goes bad, it is teamwork. And I have so many times I've had nurses who have spoken up and brought up the point that your IV bag is getting empty or whatever. I mean, we all get distracted even before WhatsApp or whatever. We are those days we had to hand ventilate, and we had to measure the BP using the manual. So I mean, it's not necessarily that you're doing something else or you're outside. Even when you're inside the operation theater, you need to have one eye on the operating field. And before patient comes into OT, you need to know exactly what the patient is coming up for surgery and what is the likely surgical technique and all. So I have had in emergency, I have been called, and after giving the spinal, when I spoke to the patient and asked, so what have you thought of names for the baby? Then she told me it's twins. So the obstetrician hadn't even told me it was twins. So I ran out and told the pediatrician that actually it's a twin pregnancy. And to this date, the pediatrician always thanks me. I remember that day you told me, you gave me just those extra few minutes. And it so happened that the first baby came out fine, second baby had some transient apnea, and the first one developed secondary apnea. So just being mentally prepared that there are going to be two babies help them to get over. So please always look at all the investigations related to the surgery. And for obstetric, please look at what is the term, whether it's cephalic, whether it's breech, where is the placenta, whatever. And every information will come in useful to you at some point in time. Not for every case, but for that one case, you'll really regret if you didn't check the details.
So one thing this morning, Uma actually used a very good mnemonic. This has been used for a very long time. ATLS, all courses is ample. A lot of times in obstetrics, they are rushing through fetal distress. Patient might be on a table and use ample. Okay. Has the patient got any allergy? What medications patient has been on? Okay. Was the last meal was patient? And then events. Events could be related to anything which has happened between the one patient was first known to have pregnant and then what happened throughout. Have they been to get their scan, echocardiogram, or things like, or they've been told anything? A lot of time, the patients actually assume, being a doctor, they think you have access to all the records. This is a common thing. It is not only I think in India, but also across the world. So, tell them, no, I need to know from you if you actually have been seeing any other doctors. Have you had any other episodes? You have anything? And tell them I do not have any access to any of your records. So that is actually very, very important. So ample, I think, will be very useful for, we get a lot of things that say, oh, when I went there, the patient was already on the table. I think you have got at least that. If you use that mnemonic, you can cover a lot of things.
Even as you're loading up the drugs or checking the blood pressure, diluting the antibiotic or whatever, constant conversation can elicit a lot of history. And of course, sometimes the obstetricians butt in and start answering on behalf of the patient. But yeah, you just tell them, no, you know what, I need those few minutes with my patient.
Yeah.
We need that private talk.
Yes, yeah, exactly. As it is like that is my time, and I think need to have that because even the obstetrician don't actually look, they're all very tubular. Obstetrician the orthopedicians, they are actually looking at bone or looking at uterus. Beyond that, they actually, a lot of times they miss out quite a lot of things.
Yes,
Sorry,
Vanilla?
Vanilla. Yeah.
No, I'm just wondering whether I should share today or keep it for an interesting case tomorrow, because the surgeon told me this lady came in very breathless, but tachypnea, as in she looked like she was going to arrest on me, just walked in from the OP into the PAC room. She said, I want to shift her up, just see her before she goes up to theater. And I just got this grave feeling, and I asked her, do you have any other medicines that you're taking? Because she was saturating very bad. She was breathless. She didn't carry a file with her. I didn't have a stet. I was walking on the corridor. She said, only skin disease, doctor, nothing else. I just took some medicines for skin disease. And I asked for old records. The husband had gone to do some admission because he was in a rush with the older child. We shift her up and you do the gas. I put an aisle and I do gas. There was CO2 was 5.
Yeah.
She was tachypnic. She was having an acute pulmonary embolism. She was about 52 kilos. Second pregnancy. She was scheduled for LSCS the day after, but came in tachypnic today. And she still didn't know. She was not going to reveal to me what disease it was. She told me it was a taboo. She did not want to talk in front of her mother-in-law. She would not tell me what it is or what medicine she was taking. Anyway, she needed to be intubated, ventilated, and we actually lost her because in the next 5 minutes, she was gone. By the time we took the baby out, and we then got, when we shifted her to ICU, we declared her 6 hours later. But she was talking to me, and I cannot forget this patient, Preeti. You know, that is a nightmare of a patient that I still can't. Her face and the baby's face next to her. She had SLE. She was told by the rheumatologist not to conceive, and she was a severe form of SLE with cardiac and respiratory involvement. But something forced her social situation that she wanted another baby. And this thing happened. And the worst part is she did the 9 months through pregnancy, the gynecologist did not know that. She was not on Clexane.
Yeah.
And that was a massive pulmonary embolism. This is hysterectomy, cesarean did not save her.
Yeah, that's the
thing. Did you manage to get a postmortem?
They did not do postmortem. Actually, you know, the whole social situation was really bad. They wanted to take her home. It was a very awful situation. I mean, but the CO2 of 5 was like, did I take the blood? Did I do this right? You know, that's sort of a doubt when you get the moment you see such patients.
Is the machine okay? Is the machine
I was like questioning the nurse, you know, like, did you do it right? You know, that sort of stuff. So, and that is when, you know, that simple question, I kept asking the husband and the wife again and again, do you have anything else to say? Did you ever go see any other doctor? And sometimes we get fooled by them. And, you know, that was their situation, and my situation that Saturday morning wasn't pleasant.
This is a problem, I think, in Indian setup is a lot of things would be directly told that, oh, this is a taboo, this should not be told. So sometimes it's not you, it is that you haven't had the full information. And maybe, I mean, obviously in case of one patient already had pulmonary embolism, you can't do much in that. But with advancing technology, I think they still say lives can be saved.
We gave the dose of Clexane, shifted to OT, you know, but we knew that the moment I intubate, the moment I give anything we do, she's going to go. We called the ICU guys in from the other hospital. We were all there. We were all ready to jump in and do, but then it was, you know, we knew it was not a repairable, reversible situation. But yes.
Yep. I think few more comments. Madhuka wants to ask, how common is hyperstimulation ovarian syndrome during ovum pickups? How to avoid this complication? Vidya, I think that was for you.
Yeah, so okay, it's I mean, normally not encountered during you know, after the initial few days of pregnancy. It's either during stimulation or thing. So there are a lot of modifications to the drugs that are used to stimulate ovulation now, and it's kind of you know, just outside our prerogative. I did some reading up. The journal articles I have shared have got a specific mention about that. So the type of drug that is used for stimulation is been a game changer now, and because of that, ovarian hyperstimulation syndrome is much less. It was encountered much more before, and that is the other advantage of frozen embryo, is that you can time it with the cycle of her normal menstrual cycle. So when the stimulation, when the preparation of the uterus is in sync with the normal menstrual cycle, the chances of ovarian hyperstimulation syndrome is much less. I'm sorry, I can't recollect exactly the name of the drugs, but that's what I did read about that. That's what it is basically.
Vanilla.
Vanilla, could you please clarify?
No, I'm not sure of the names, exact names of the drugs either, because I think they are also an evolving specialty and different units trial and error different drugs. But with regards to egg collection patients who come, if they've had multiple stimulations, especially when the egg donors who have exaggerated response to the drug induction, ovulation induction, then we tend to give them less crystalloids but more starch, and because we've had a couple of patients who've developed pulmonary edema about 4 or 5 hours later because of the reabsorption syndrome and IV fluids.
Indications for albumin.
Albumin or starch. I think we use starch for such patients. We start in theater itself at 100 ml per hour, keep them through in recovery, make sure they have peed well, they are breathing okay before shifting to ward. And with such patients whom we see 22 eggs, 24 eggs, not the non-responders. Responders that are the problem. If they have a lot of eggs, then we go and check them before they get shifted from daycare for discharge. I personally, whoever the anesthetist is, because often the gynec registrars don't do air entry. So we go check them, make sure they're okay before they go home. Okay. And the IVF unit is clued into it now. So the nurses are also checking on those parameters.
Perhaps one of those reasons for holding back the patient overnight, if you're not happy, if you're not happy. HS has been diagnosed, then perhaps better not to discharge the patient.
Start last 6 and observe them. Yes, absolutely.
Okay, I think this will be the last comment, and I think it's past 7 o'clock in India.
Yes.
Am I right? Okay. So DSP actually made a very relevant comment. Okay, this is about endogenous oxytocin. Now, the cesareans which are done in patients who are already in labor pain, now they tend to release, according to the endogenous oxytocin has already been released. It's almost 7 to 8 times more than the normal levels. And this might be helpful in patients that their chances of developing PPH is much less compared to someone who has never had. So this is patients who are on elective cesarean sections are probably a lot more likely to be in PPH than patients who are actually had labor pain, then rushed to the theaters. Okay. So that was a comment from
the other thing is the reverse may happen for those who have already been on oxytocin, those who have been induced.
Induction,
and they've had oxytocin, then when you give oxytocin, it may not work. So
exactly,
it's a double-edged sword. Spontaneous labor, unaugmented, though they will do well. But if they have been on oxytocin drip for a long time, half the day or something, and then land up, then those are again patients where you have to maybe quickly move to another thing like carbetocin or something early if you suspect PPH, rather than continuing with oxytocin.
Absolutely. I mean, when you are on oxytocin for a long time, you have down-regulation of receptors, and what are you going to do? You're not going to get much of that, I think.
Yeah, for actually elective LSCs, we also do prime the patient, just before the procedure is about to begin. We just put in 5 units of oxytocin into the pint, and we go on at a very slow rate, maybe 8 to 10 drops per minute, so that the receptors are primed by the time the baby is out. Again, the timing here is very important so that you don't end up with a fetal distress. So depending on the surgical skills of our obstetrician friend, that's how we manage them. So we try
I'm just paranoid. I mean, I just can't bring myself to do that.
Our setups, the kind of practice that we do here in rural areas, we know exactly how long somebody will take. 2 minutes here or there.
Absolutely. I think the surgeons are very quick in India. I think I've seen Vidya knows Professor Rajaram, seeing them do a cesarean was like where you just go one and then baby next, let the baby come out. I mean, those kind of people, they were amazing surgeons in India. So yes, delivery of
Bowel
babies.
handling is so less. So they don't do unnecessary handling of tissues.
Yeah.
I've worked with a surgeon who does his skin to skin extraperitoneal C-sections in 7 minutes.
Yeah, that's
Even go see another
impossible to
patient.
see in UK.
Yeah.
By the time your spinal hypertension starts, sees out, you are left with a patient whose blood pressure is beginning to come down.
No, nothing happens to his patients. His wife is an anesthetist. So he's seeing his patient, she paints, drapes, calls him. The moment the spinal is in, he walks in, 7 minutes, patient is out. And in that much time, they've just taken out one OPD patient and taken the next patient in. He's taken out so fast. And he's awesome. He's beautiful. It's magical to see him work.
All right. Okay. So the last two comments are, this is from Dr. Prema Rajgopalan, saying great discussion. Congratulations, all speakers. And Dr. Dilnaj, excellent symposium. And all the speakers and faculty are wonderful. All right. Thank you. Thank you very much. It's 7:10 in India. And I think it's been a wonderful discussion and wonderful thing. I didn't mention it that this was all women's team. So Nari Shakti was in. and all of you did an absolutely wonderful job. We'll look forward to another one. And we have crossed 300 views already.
Thank you. Thank you, Shiv.
And this will grow because people are still watching this. They will continue to watch. By tomorrow, I expect it to actually be more than 500.
Wonderful.
Thank you, sir. Thank you, ma'am.
Thank you very much.